Okay. Well, good morning or good afternoon, depending on where you are. Welcome to the Advisory Committee on Infant Mortality, our September meeting. I'm Vanessa Lee. I'm the new designated federal official, or DFO, as we fondly call it, for the committee. I have big shoes to fill with Captain David De La Cruz's departure for another position, and I'm just really honored and excited to be in this new role to support the committee. I'm officially calling the meeting to order and opening it up. So before we do introductions, I'll turn it over to our committee chair, Ed Ellinger, for another welcome.
Thank you, Vanessa, and good morning, good afternoon, and good evening to everyone on this last day of summer. The autumnal equinox is coming. Tomorrow is the first day of fall. Good place to eat when we have equal light and day. So welcome to this virtual meeting of SACIM. Also, this is the United Nations International Day of Peace. And as you're probably well aware, the World Health Organization puts peace at the top of their social determinants of health pyramid. So it's a good day to be thinking about peace. That would really help moms and babies throughout the world. Also, this is the beginning, the first day of Sukkot, which runs for the next week. And the first 2 days of Sukkot, which is basically today and tomorrow, tradition instructs Jews to eat and sleep in the sukkah, a traditional hut or a tent. And they do this to inhabit the experience of living without and the experience of having an impermanent home. And this is what many generations of Jews have experienced while fleeing persecution and poverty for many centuries. But today, thousands of other families don't have access to safe and stable homes, not only because of war or expulsion, but because of poverty and housing and economic policies. And certainly we know that safe, stable, and secure housing is a major determinant of health, especially for infants and children. And Sukkot is also experienced as a way to gain a new perspective on vulnerability. So I want you to keep Sukkot in mind, the 2 days when these first 2 days of Sukkot are the 2 days of our meeting. Let's keep Sukkot in mind for the sake of vulnerable infants. Let's inhabit the experience of being vulnerable. And it's also in that spirit of experiencing being vulnerable, I have to share that in the last year, I have had the privilege to work with several state and local health departments and healthcare systems, particularly maternal and child health programs across the country. And in my 50 years of working in healthcare and public health, I have never seen public health and medical care professionals so stressed and feeling so vulnerable at this point in time. At a time when their expertise and experience are most needed, many are feeling unappreciated and unsupported. At a time when we have more health care and public health tools than ever before, public health and medical care recommendations are frequently being challenged, ignored, or even contradicted. At a time when we have the greatest need to change systems to advance health and health equity, these professionals are constrained to act. In fact, many cannot even use the word equity or talk about racism. And at a time when everyone should be coming together to address an existential challenge like pandemic, people seem to be further apart than ever before. So this sort of reminds me of Charles Dickens 162 years ago on this month when he wrote about the French Revolution of 1789. He said, and you know this well, it was the best of times, it was the worst of times. It was the age of wisdom, it was the age of foolishness. It was the epoch of belief, it was the epoch of incredulity. It was the season of light, it was the season of darkness. It was the spring of hope, it was the winter of the despair. We had everything before us and nothing before us. As I interact with the public health workers across the country, and even people in my neighborhood, we seem to have come up against this worst of times, more so than the best of times. And certainly now, in this day and age, just like in 1789 and 1859 when Dickens wrote that, the worst of times scenario is precipitated by a conflict of seemingly incompatible ideologies and perspectives that shut down dialogue and mutual problem solving. And that's why our work, the work of SACIM, is so important. because we have the opportunity to have some of those needed conversations about issues that might be controversial or we might have conflicting opinions, and we need to model how to discuss issues in a respectful and responsible way. We can do the things that many public health officials throughout the country cannot do. So this is why our work here today is so important. And core to discussing this kind of discussion is maintaining a focus on the values, not on the ideologies, which all of us possess. We all have ideology, but let's focus on the values like equity, community resilience, lived experiences, objective data, both qualitative and quantitative, prevention, openness, and humility. These are the values that will help keep us grounded and help us to recognize that issues are rarely black and white. These values will help us to come to conclusions which benefit all members of our community. So that's what I hope drives the work of SACIM today and forever. And among those values that I think are important are being bold and strategic. And I bring those up because at our last meeting, former Secretary Sebelius told us to be bold. And so I want you to be bold. I want you to bring forward ideas. We to have good, robust discussion and think about how we can advance the work of SACIM beyond just our virtual Zoom and among our members. We need to be able to really be bold and advance the agenda, the recommendations that we put forward. So with that little background, I want you to be bold and introduce yourself. And normally I would have longer introductions, but we do have a tight agenda and we have a time constraint with the Assistant Secretary of Health who will be joining us at the bottom of the hour. So I would just like to go around and have people introduce yourself, both the members and the ex officio members. And I'm Ed Ellinger. I'm the acting chair here in Minnesota on Dakota and Chippewa land, and glad to be your acting chair. And I'll go around on Tara.
Good morning. I'm happy to be here. My name is Tara Sandra Lee. I'm a scientist and the Senior Fellow and Director of Life Sciences at the Charlotte Lozier Institute. And, I'm looking forward to a couple of days of great discussion. Thanks, Ed.
Good. Jean Conry.
I'm Jean Conry, past president of the American College of Obstetricians and Gynecologists and president-elect of the International Federation of Gynecology and Obstetrics.
Welcome. Magda Peck.
Good morning, Magda Peck. I woke up in Richmond, California on Oholone, Mukweka, and Chincheño lands. I am an independent consultant for public health and equity with MP3 Health. I'm the founder and senior advisor to CityMatch and an adjunct professor of pediatrics and public health at the University of Nebraska Medical Center. Also the co-lead for the Data and Research to Action work group on SACIM. Good morning.
Yeah. Good morning, Steve Calvin.
Hi. Yep. Hi, Steve Calvin. I'm a maternal fetal medicine doctor here in Minnesota, and I work with midwives to try to provide a different model of midwife-led primary maternity care that's integrated with the current system. Happy to be here today.
I'm glad you're here. Paul Wise.
Good morning. I'm Paul Wise, professor of pediatrics, health policy, and international studies at Stanford. And for the past 2 years, I've been appointed to the federal court overseeing the treatment of migrant children in U.S. detention. Thanks, Ed.
All right, good, glad you're here. Janelle Palacios.
Hi, good morning, everyone. My name is Janelle Palacios. I'm Salish and Kootenai. I'm a nurse midwife. I have been for the past 11 years. I work in the Bay Area, and I am a co-chair of the Health Equity Work Group with Belinda Pettifor. And I am also a research consultant and have expertise in American Indian women health.
Glad you're with us, Janelle. And Janelle shared that she doesn't have childcare, so we may hear some little voices in the background periodically.
Yes, and ambulance voices.
Colleen.
My name is Colleen Malloy. I am a pediatrician and neonatologist in Chicago. I work for Lurie Children's Hospital and Northwestern University Feinberg School of Medicine. And I work in level 2 and level 3 NICU in the Midwest.
Good. Glad you're with us. Belinda, I don't see your picture here. Belinda, I hope you're on.
Belinda shared that she had to reboot her computer. So as soon as that is finished, she'll be able to log on.
All right. And is Paul Jarris on? I don't see him. All right. So welcome to all of the SACIM members. Let's go through the ex officio members. Wanda Barfield.
Good morning and afternoon to everyone. My name is Wanda Barfield. I direct the Division of Reproductive Health. I currently reside on the land of the Creek, Muskogee, and Cherokee. And I am also a neonatologist by training. Great to see everyone.
Allison.
Good morning, everyone. I am Allison Cernich. I'm the Deputy Director of the Eunice Kennedy Shriver National Institute of Child Health and Human Development, and I am a neuropsychologist by training.
Okay. Karen Remley.
Hello, Karen Rimley, pediatrician and the director of the National Center on Birth Defects and Developmental Disabilities at the CDC. Thank you.
Kristen Zickerman.
Hi, I'm Kristen Zeikerman. I have a background in labor and delivery nursing and research, and I am at the Centers for Medicare and Medicaid Services as the MIH SME and the lead of the Maternal Infant Health Initiative.
Good. Joya.
Hello, I'm Joya Chowdhury, representing the HHS Office of Minority Health. Thank you.
All right. Now, anybody else, any others ex officio members that I haven't identified?
I'm here. This is Kamala Mystery from ARC. I'm the Senior Advisor for Child Health and Quality Improvement and also the Associate Director for Extramural Research, Education, and Prairie Populations.
Good. Welcome.
Good afternoon. Michael Warren. I'm the Associate Administrator of the Maternal and Child Health Bureau.
All right.
I'm Danielle Ely from the National Center for Health Statistics, and I work on the linked birth and infant death file.
Some of these names just pop up out of nowhere, so that's why I'm sorry I didn't connect you earlier. Lee.
Good morning and afternoon. My name is Lee Wilson. I'm the Director of the Division of Healthy Start and Perinatal Services in the Maternal and Child Health Bureau. Thank you.
All right. Good. All right, well, welcome to you all. And before we get into our major part of our agenda, we have another major part of our agenda, which is to recognize Captain David Dela Cruz, who was our designated federal officer, our DFO, for 15 years. And during his tenure as DFO, he has onboarded and guided and supported several cohorts of SACIM. And he's the one who brought all of us into this committee and provided the support and the guidance and direction for both our in-person and our virtual meetings. And as acting chair, which I've been acting chair now for 3 years, I don't know how you ever get to become actual chair, but anyway, as acting chair, David was very responsive and always looking for ways to enhance the impact and effectiveness of SACIM. He did that in addition to all of his multiple other duties in MCHB and at HRSA. And recently, as part of his work as a commissioned core member of the U.S. Public Health Service, he's been detailed to work on COVID issues both in Texas and now at the U.S. Customs and Border Patrol headquarters in Washington, D.C. And this has taken him from his work in his MCHB role. So I really wanted to bring David back so that we could all recognize him. He's been a joy to work with. So David, thank you for all your work with SACIM and particularly working with me. I've really enjoyed it, and really best wishes for whatever lies ahead for you. So everybody on this call, why don't you just kind of give him a clap and great thanks for the work that he's done over all of the years. So David, thank you,
David,
very much.
Thanks.
Well, thank you. That's incredibly kind and very unnecessary. It was really an honor and a privilege to work with so many outstanding leaders. And, many years ago when I started this, I felt very fortunate to be in the presence of some of the people I studied when I was in school and some of the people I I really looked up to, and to be able to sit at the same table as many of you is a real honor. And I thank you all. This is very unnecessary, but very much appreciated. So thanks very much.
Right. Well, I'm going to put you on the spot, David, since you are here. What have you seen SACIM do in the 15 years that you were DFO? What were the accomplishments that you're proudest of for the committee that you basically supported?
Yeah, I think the continuing to be a voice of a population that doesn't always have a voice, to increase the visibility of some of our most vulnerable populations and communities to the very highest levels at HHS and beyond, I think is something that is good and noble work and should be remembered and should be something that is continued, a continued priority. And you all are under very good leadership with Dr. Warren and others. These are folks who are committed to making sure that the populations that we serve and the communities we serve are given the best possible chance at optimal society and optimal life. And I think that raising these issues to the highest members, the highest levels, is incredibly important and something that needs to happen. It's something that you all remain committed to and work very hard at. And it isn't always recognized, perhaps, and it isn't always thanked, but it is something that is incredibly important. And one of my very first mentors, Dr. Vince Hutchins, was one of the people who always described this as good and noble work, and it's work that will never make us rich and or famous, but there's lots of ways to measure wealth and to measure value. And I think each of you lives that every day, and it's just a real pleasure to have been an extremely small part of that. But really, it's raising the visibility and raising these issues, keeping it in the forefront of the people who make some important decisions, whether that's policy or funding. I think that's probably the greatest achievements that we've done as a committee.
And we'll be talking about that when we talk about the recommendations that we submitted to the secretary. But do you have any suggestions on how we can actually increase our effectiveness? Are there any strategies that we should be thinking about?
Now that I'm not at HRSA, maybe it's easier for me to say this. Be persistent. Don't give up. The work that you are doing is too important to stop at the first no. Just keep going. Don't be satisfied with the status quo. Don't be satisfied with a general response back. I was teasing Vanessa earlier, saying that as this being her first meeting as the official DFO, somehow she managed to score the ASH. What a great opportunity to not only hear from her, but perhaps even more importantly, share with her the good work that you all are doing. Just keep pushing to be heard and seen, because too often the populations you serve are not being heard and seen.
Great.
David, can I ask one question? Would you share with the group what you're doing now?
Oh, sure. So I'm at Customs and Border Protection's Office of the Chief Medical Officer. I'm the Medical Operations and Emergency Response Coordinator. So when I started back in March, it was really mostly COVID, but it has quickly changed to dealing with the increase of people crossing over the border. And Dr. Wise, I work day to day with Jerry Kraska, who I know you work with some of the issues that the treatment issues and the advocacy work that you do. So I provide coordination, support, and leadership for different teams that are down along the border, making sure they have everything they need to succeed as they work in these border patrol stations or Office of Field Operations. It's very different work than where I came from. I'm reminded on almost a daily basis, this is a law enforcement agency. That is not my background. But very, very luckily, I'm able to bring in a lot of my maternal and child health experience in this work, because so many of the people that we're serving are unaccompanied minors.
Well, thank you, David. Thank you for the work that you're doing now, and thank you for all of the work that you did for SACIM. I really appreciate it, and I hope I get to work with you sometime in the future again, because it
would be my pleasure, sir. It would really be my pleasure. It was great work with each of you.
All right, very good. And I see Belinda is now on. Belinda, could you introduce yourself?
Yes. Hello, everyone. I was going to say good morning, but it's not morning where I am. But hello, everyone. It's good to see everyone. I'm not sure what my computer challenges were this morning, but I'm on a second computer, so we're going to hope this one works. I am Belinda Pettiford. I'm in North Carolina with the State Department of Health and Human Services. And there I serve as head of women's health, which includes the maternal child health programs in our state, including reproductive health, as well as our state sickle cell program. So good to see y'all.
Well, I think we've got all of the members except for Paul Jarris, and I know Paul Jarris was biking across the United States because I know he came through Minnesota, and I assumed he was going to be done by this time, so maybe he's still in, I don't know, Pennsylvania or something and can't get on, but I haven't heard from him. So we got everybody else. Anybody else who's come on that from any ex officio members that we haven't introduced? All right, if not, I will turn it back over to Vanessa, who will introduce Diana Espinoza.
Great, thank you. And it's, yes, now my pleasure to introduce our acting administrator of HRSA, the Health Resources and Services Administration, Ms. Diana Espinoza. She has been the deputy administrator of HRSA since March of 2015, and prior to that, served as a senior health advisor to the HRSA administrator from 2013 to 2015, and provided counsel to our administrator at that time on a wide range of policy, program, and management issues. Before joining HRSA, she was with the Office of Management and Budget, serving as the Deputy Assistant Director for Management. And before her federal service and all of the work she's done with us at HRSA, earlier in her career, she served with the Miami-Dade County government, where she held a number of posts, including operating budget coordinator. Ms. Espinoza attended the University of Michigan, where she received her Master of Public Policy. And I'll now turn it over to her.
Well, thank you. And good afternoon, everyone. I just want to wish good afternoon to our committee members, ex officio members, HHS, MCH leadership, everyone in attendance. As Vanessa mentioned, my name is Diana Espinoza, and I am HRSA's Deputy Administrator, and I'm currently serving as the Acting Administrator. And so I'm very excited to be with you today. I think it's been several years since I've had the chance to visit with this committee. At the outset, I just really wanted to thank you all for your service and commend you, for the great work, the hard work that you've been doing for a while, but especially over the last year and a half. I think, there are extra challenges to doing everything under COVID. Obviously, this is one of the, the biggest public health challenges that the world has experienced, in the last 100 years or so. And I just really appreciate that you all have remained engaged and passionate about the work that you do. Your committee is a widely respected group, and our agency very much appreciates the counsel and thoughtful advice that you've provided over the years. And, we share your goals of preventing infant and maternal mortality and improving the health of all mothers and children. And I do, I really wanted to assure you that HRSA does value your feedback, and we continually work to integrate your guidance and recommendations into our programs. Your commitment to eliminate disparities and achieve better maternal and infant health in vulnerable populations is clear in your most recent recommendations to the Secretary, and aligns very much with the priorities of the Secretary. Today, I will just mention a few updates on some of the work that HRSA is doing that I think relates to your priority areas. Before I do that, I'd also like to take the opportunity to acknowledge Captain De La Cruz. David has served as this committee's designated federal official for many years. And I obviously had the opportunity to also work with David and his great work with the Healthy Start program. And just, you know, I guess it's a strange world where like I get to say goodbye after you've already left and haven't seen you for months. Don't have those, you know, passing in the building kinds of things. But I just wanted to thank you, David, for your leadership in managing this advisory committee and your steadfast support of its members and their work. You know, this committee has always been one of our more active and engaged committees, and I'm sure that is in a large part due to David's leadership and dedication, you know, as a DFO. You know, I know we will miss you at HRSA, and you know, you've done incredibly, you're doing important work. Thank you for sharing that. I also appreciate that, you know, during your time at HRSA, you just, you know, always stepped up where you were needed, and that obviously was also with your commission core responsibilities since you were deployed many times over the last few years, but just wanted to thank you. And
thank you, ma'am.
Oh, sure. And you can always come back and visit us when we're all back in a place where you could visit us all at one time. So moving on to our updates, I just want, as I mentioned, I wanted to share some of the priority areas that that HRSA is working on that align with your recent recommendations to the Secretary. For example, you know, we know that the longer that the pandemic lasts, the more health workers, especially those serving in rural areas and communities of color where the pandemic has hit the hardest, are likely to continue to face challenges, including mental health challenges. And because of that, I'm, you know, especially pleased to report that through the American Rescue Plan, HRSA received some funding and has $100 million that we will be awarding for organizations to work on reducing burnout and promoting mental health among the health workforce. And so, you know, I think all of you appreciate, you know, that it's essential that we provide behavioral health resources for our healthcare providers. And this doesn't, you know, obviously this includes physicians and nurses, but also includes paraprofessionals and public safety officers, and, you know, the wide range of people that are truly on the front line so that they can continue to deliver quality care to our most vulnerable populations. You know, I think that these three new programs that we have will hopefully help kind of begin to address these issues and make sure that we build this in as a regular part of health professions training, that wellness be incorporated, you know, for the long term, as well as addressing the current immediate needs that we're all facing. Later today, you'll hear more about these efforts from our HRSA's Bureau of Health Workforce. We've also made important investments to strengthen telehealth services in rural and underserved communities and to support pediatric mental health care access. And we've also recently elevated that telehealth function in our agency because of the importance of telehealth in providing healthcare, especially to underserved communities. In addition, we are responding to recommendations you've made to support pregnant women, mothers, infants, and children, in particular those near our country's southern border. And already, you know, I'm proud to report that HRSA has dispatched our own staff, both members of the Commission Corps and civilian employees, to provide as much assistance as we can to help keep families safe and together. And finally, we at HRSA, are resolved to continue our emphasis on health equity through all our bureaus, as you outline in your recommendation. I think, health equity is core to our mission. It's built into all our programs, and where it can be strengthened, we will make sure we do that. I think that, we will always really value this opportunity to bring a concerted focus on health equity as it is central to everything we do in our agency. And you'll hear more specifics later from our Maternal and Child Health Bureau on our efforts to improve health outcomes before, during, and after pregnancy. You will also hear an update on our work to reduce racial and ethnic disparities in infant mortality rates, including supplemental funding for Healthy Start grantees that supports community-based doulas and infant health equity efforts that we announced on September 17th. Again, I just want to thank you and just emphasize that your recommendations, ideas, suggestions, feedback are all critical as we continue to support women, infant, and families. And I look forward to our continued collaboration and thank you for your service. And so now it's my pleasure to introduce our Assistant Secretary for Health, Dr. Rachel Levine. Dr. Levine serves as the 17th Assistant Secretary for Health for HHS, where she fights every day to improve the health and well-being of Americans. HRSA is fortunate to have her as an excellent partner, as much of our missions overlap and complement and are working in the same direction. She's working now to help our nation overcome the COVID-19 pandemic and bring a brighter future, one in which every American can achieve their full health potential. Dr. Levine's career includes a wide variety of work in different fields, from academic medicine, working as a physician, serving as Pennsylvania's Physician General, and more recently as Pennsylvania's Secretary of Health. And as a physician, she focused on the intersection between mental and physical health, often treating children, adolescents, and young adults. She's also the author of numerous publications on the opioid crisis, adolescent medicine, eating disorders, and LGBT medicine. With that, I will turn it to Dr. Levine.
Well, Diana, thank you so much for your very kind introduction. I'm really pleased to join you all here today. And I've told you before, I love HRSA. I mean, I think HRSA does such a fantastic job supporting public health and healthcare really throughout the United States. And I'd really like to thank your outstanding team at the Maternal and Child Health Bureau for all of their efforts supporting this advisory committee. I certainly recognize the importance of my role as the Assistant Secretary for Health. As Diana had talked about, I come from a career in academic medicine at Mount Sinai in New York City and Penn State, where I was for about 20 years. And I am a pediatrician in my initial training, and then an adolescent medicine subspecialist. I've also, as you mentioned, been the Physician General of Pennsylvania and then the Secretary of Health in Pennsylvania. And so, I certainly understand the value of public service, and I really would like to thank you all for your commitment and dedication to serve and provide leadership to reduce infant mortality and improve the health status of pregnant women and infants. It's just absolutely critically important. I also will talk about the COVID-19 pandemic at first. It has been a very difficult and challenging time. It has caused tremendous challenges and suffering for millions of people in America and really throughout the globe. We all have felt the strain. It has been particularly challenging for public health professionals and, of course, for medical professionals. And it continues to be the biggest public health crisis that our nation and the world has seen in over 100 years. It has impacted all of us. It has impacted our health, our families, our hospitals and healthcare systems, our schools, our businesses, and has impacted governments at the local, state, and federal level. I certainly want to encourage anybody that has not received their COVID-19 vaccine to please go get vaccinated, and encourage your family and friends and community to get vaccinated. We have actually a very, very vigorous community core for coronavirus. And so we encourage people to be spokespersons, whether it's officially or unofficially, of our safe and effective vaccination programs, because the more people that get vaccinated, the quicker we can work through this pandemic. You know, as you are all aware, pregnant and recently pregnant women are at a higher risk for civilian illness from COVID-19 than non-pregnant women. Additionally, pregnant women are at higher risk for preterm birth and higher risk for other adverse pregnancy outcomes. In August, the CDC released an analysis of data from the V-Safe Pregnancy Registry that assessed vaccination in pregnancy. The CDC found that there was not an increased risk of miscarriage among nearly 2,500 people who received one of the mRNA COVID-19 vaccines before 20 weeks of pregnancy. Miscarriage typically occurs around 11 to 16% of pregnancies. The miscarriage rate after receiving the COVID-19 vaccine was around 13%, which is right within that expected range. Previously, data from 3 safety monitoring systems did not find any safety concerns for pregnant women who were vaccinated late in pregnancy or for their babies. So that includes late in pregnancy or for their babies. So combined, this data with the known severe risks of COVID-19 during pregnancy demonstrate the significant benefits of receiving COVID-19 vaccine for pregnant women, and it outweighs any known or potential risks. The increased circulation of the highly contagious Delta variant and the increased risk of severe illness and pregnancy complications related to COVID-19 infection make vaccination for pregnant women more urgent than ever. We need to encourage all pregnant women or people who are thinking about becoming pregnant, and those breastfeeding to be vaccinated to protect themselves from COVID-19. The vaccines are safe. They have an excellent safety record. They are effective. And it has never been more urgent to increase vaccinations as we all face together the highly transmissible Delta variant. And we see the severe outcomes from COVID-19 among unvaccinated pregnant women. This is such a big issue. It is absolutely tragic to see the illnesses and the deaths that we are seeing. You know, an important lesson of the pandemic is that we are all interconnected. We are all interconnected, and we have to make sure that a healthier future includes addressing COVID-19 and addressing the health disparities that COVID-19 has shown, the health disparities that exist in the COVID-19 response, and those health disparities that COVID-19 has shown us. So health equity, as Dinah was mentioning, is an absolute priority of Secretary Becerra, and it's the Secretary of HRSA, and it's a priority of HRSA, and it's an absolute priority for OASH as well. And in the child maternal health space, it's a priority. COVID-19 has certainly impacted some communities more than others, communities of color, among the African-American community, the Latinx community, among the American Indian and Native Alaskan communities, among the AAPI communities. It has underscores the profound disparities in health that have plagued our nation. And so we want to pursue a comprehensive approach to advancing equity and health equity for all throughout the Biden-Harris administration and throughout HHS. This includes the creation of the COVID-19 Health Equity Task Force, which will be making recommendations to the president. I want to highlight that our next meeting is Thursday, the 30th, in about a week and a half at 2 o'clock. So you're pleased to participate and submit your feedback. As you are aware, racial and ethnic disparities in maternal health exist and contribute to poor health outcomes. Pregnancy-related mortality is 2 to 3 times higher for non-Hispanic Black and American Indian and Alaska Native women compared to white, Hispanic, and AAPI women. I want to share a few projects that 2 program offices within OASH, the Office of Women's Health and the Office of Minority Health, are working on related to these maternal health disparities. So OASH's Office of Women's Health is working to expand available maternal health data and create a network of at least 200 hospitals to deploy clinical evidence-based best practices in maternity care. Over 150 measures will be captured to look at and understand clinical and non-clinical factors that impact maternal infant outcomes with a focus on health equity. OWH will leverage this data, improving performance improvement methodologies to scale advancements in care for mothers and infants across the nation. OWH has also launched a national competition to identify effective pre-existing programs that care for people with hypertension, and where programs could be applied to women with hypertension who are pregnant or postpartum as well. The goal of this innovative competition is to focus on racial, ethnic, and urban-rural disparities and demonstrate sustainability and the ability to replicate or expand a program that provides effective monitoring and follow-up. In October, the Office of Women's Health will lead National Women's Blood Pressure Awareness Week as well. Now, in support of HHS's Maternal Health Action Plan, the Office of Minority Health and CDC's Division of Reproductive Health launched a series of partnerships to support state maternal mortality review committees. We did this actually in Pennsylvania, where we established an MMRC to help expand the reach of CDC's Hear Her campaign to American Indian and Alaska Native women. And so this partnership with OMH and CDC to expand this campaign is absolutely critically important. And I understand that CDC will be discussing the details of these projects later. Finally, I just want to mention that we're working on the issues of mental health and substance abuse as well. This is something I worked on significantly in Pennsylvania. And we're working with a diverse group of stakeholders to develop a standard definition for neonatal abstinence syndrome, which includes a bioethics analysis to address unintended consequences. And we're grateful for feedback they receive. So at the end of the day, I know I am motivated by being able to help people in the public health sector. I know that all of you have that motivation as well. You know, we are in a position to make a difference in people's lives. And that's what you've done through these unprecedented times, to make a difference for moms and babies. So we will face all of the many challenges that we have together, and we will work together to build a safer and healthier world for all of us. So thank you. And I believe we have time for a few questions. I do have a hard stop right before 1 o'clock. Thank you so much.
Dr. Levine, thank you for being here, and thank you for your comments, and thank you for the support that you've got. I have just one comment and one question. One comment is that you talked about the pandemic as being the greatest, public health challenge of the last 100 years. I think that it is a syndemic. It goes along with the structural racism that actually causes the same number of deaths. So I think we should sort of blend those things as syndemics that exist simultaneously and feed each other in negative ways. So, but the question I have is, a year ago, this committee made recommendations to Secretary Azar about COVID, and many of those recommendations are related to moms and babies. They're still current. And then in August, we set some recommendations to Secretary Becerra. I'm curious, how do those recommendations ever come to you, and in what form do those recommendations come to you so that they can inform the work that you do? I'm just curious about that process.
Sure. Well, the process is that is certainly that our Office of Women's Health and will bring those to me, and also HRSA and OASH collaborate really closely. Diana, would you want to comment?
Sure. I think that, as far as recommendations from the previous administration, we can certainly re-up and look at those because, as you know, they're still relevant. As Dr. Levine mentioned, she and I, we meet on a regular basis, but the staff are interacting, almost on a daily basis on a variety of issues. And we can certainly take a look at that, take a look at those recommendations. You do raise a good point though, as far as we probably should think about building in some regular routine structured ways of making sure that OSH has an opportunity to engage. Because I mean, when they go to the Office of the Secretary, various people get involved, but we can certainly, from the HRSA end, actively engage OSH on those recommendations.
Thank you. We're very pleased to collaborate and work together in any way.
And any members, if you have a question, just raise your hand on the little raise hand thing at the bottom of your screen. While we're waiting for that, Dr. Levine, how can you leverage SACIM, and how can SACIM leverage your office for the things that we're in similar work of same mission, same vision of what we'd like? How do we leverage the work that you're doing and you leverage the work that we're doing?
Well, I think that again, we're very pleased to meet and to work together and to collaborate. I mean, I think one of the things that you all can do as an organization, but also individually, is to advocate for vaccinations for COVID-19, and specifically to advocate for vaccinations for pregnant women. We are speaking with ACOG about this, about how we can leverage and work with our nation's OBGYNs about this. But, we are just seeing far too many pregnant women getting COVID and either suffering severe medical complications, having, potential complications to their babies, or to, in tragically dying. Frankly, so that I think that the more that as an organization you can speak, so that we're all in one voice, and the more that you can speak in your local areas as local trusted professionals, the better that would be.
Good. Tara, you have a question?
Yes, and I apologize for the background noise, but just a quick question. First, Dr. Levine, thank you very much for your presentation, and I share your concern about vaccination. I was just wondering if you could give a quick update on what HRSA and HHS are planning to do to increase vaccination rates at the border with those that are crossing on a daily basis.
So there are specific efforts to address the border. It's a all of government response. It involves HHS. It also involves the Department of Homeland Security, et cetera. The Secretary is absolutely committed to this mission. It does involve aspects of OASH because it involves the Public Health Service Commission Corps, and we have officers that are stationed at the border. ASPR has a very large, important role in terms of that, as does the Office of Children and Families and the Refugee Office as well. And so we are working to address all aspects of that, but also particularly when possible, immunizations for COVID at the border as well.
Thank you.
Dr. Levine, as both of us being former presidents of ASTO, recognizing that public health is under attack and its credibility has been, sort of threatened over the last, year. What are you doing to sort of generally increase the credibility, restore the credibility of public health to the general population, but also to support the public health workers themselves as they're stressed in this really, really traumatic time?
So you're entirely correct. This is the COVID-19 and has been such a challenge for frontline medical workers, whether they're in the emergency department, whether they're in the ICU, whether they're in their offices, whether they're in the delivery room, whether they're on the wards, but it also has been tremendously challenging for public health professionals. And I've seen that at the state level as the Secretary of Health of Pennsylvania, but also now at the federal level. I think that we need to view public health professionals, whether they're the state health officials or whether they're epidemiologists or vaccine managers or whatever, as frontline workers as well in terms of that. I think that we need to support them. I think that we need to have collaboration and coordination at the state, local, and federal level. In fact, the call that I'm jumping to at 1 is a call that we have weekly with NACCHO and ASTO and big cities and CSTE and APHL and others to make sure we're exactly on the same page. And I think that we're going to need sustainable funding for public health at all of those levels to be able to learn the lessons from the pandemic and to continue.
Thank you. Dr. Peck.
Well, thank you, Dr. Levine. As an old Philly girl, it's great to see you in a leadership role. Thank you so much for what you're doing in governmental service at the next level. I'm curious about what advice you have and how you're handling the politicization of data. I lead the Data and Research to Action work group of SACIM, and we are certainly advocating for stronger data systems, greater data capacity. But how are you handling the doubt of data and the pushback and the messaging when science doesn't speak for itself? Just wondering if in your short tenure there and obviously previous tenure in other leadership roles, how do we deal with the doubt of science and the suppression of data in some areas and the politics overriding the science and the evidence?
Well, it's an excellent point. I think that we all need to work together on this. I think one of the significant challenges of our public health response to COVID-19 at all levels has been the politicalization of the response. I think that this is not in any way a political issue. This is a public health issue, and we need to let public health, medical and public health professionals lead the way. We are doing that in the Biden-Harris administration. Many of us in public health leadership positions, we meet together on a regular basis, several times a week to talk about the data, to review the data. The CDC is being very transparent with their data, and we want to work with state and local public health officials in terms of that transparency as well. And then we're letting data drive the decisions, the public health decisions that we're making. I think we do the best we can to explain that. I think we can always do better in terms of our communication about data and our communication about our public health decision making, and we will continue to do that. My last words are, and I'm going to have to jump, I'm sorry, we're going to need to push back about misinformation. Our Surgeon General, Dr. Murthy, has had a whole program about that and published about that in terms of trying to push back on misinformation in social media and in the media as general. And we need your help, again, as an organization and as trusted local leaders to be able to do that. So thank you so much. I'm actually going to have to jump to the next call, which is that call with local and state health officials and other public health leaders that I have to be able to explain about boosters and to talk about childhood vaccinations, to talk about schools and how we can do a better job in terms of trying to keep our kids in school. And then, potential new information about childhood vaccines that we hope to be receiving data from Pfizer, and then how the FDA and the CDC will be looking about that. So that's my next call, and I'm being totally transparent about everything that we're talking about. Thank you so much, and take care.
Dr. Levine, appreciate it.
Thank you so much.
And also thank you, Ms. Espinoza, for joining us also. We really appreciate that. It's nice to have the HRSA administrator and the ASH. That is, at the same meeting. It's really a treat to have that.
Oh, thank you.
All right, and so on our agenda, we have a little discussion, a short period of time, really to discuss the recommendations that we put forward in August. And I put that on there just to really make a couple of points. And you notice that the Dr. Levine really didn't talk about our recommendations. And that's why I asked the question, how do those things get up to the space where she can actually see them? What is the process? And because if the recommendations we make don't go anywhere, why would we want to continue to do that? And I'll get to, I know Lee probably has some response to that. But I'll hold on to that for a second. But I want to increase the visibility of our recommendations. And I want to find some way to evaluate how those recommendations move and how they get acted on, because otherwise we don't feel like maybe some will feel like the effort's really not worth the effort if we don't do that. So I've done a couple of things, and I asked some questions of you. How have you shared the recommendations that we made? Have you shared them with your partners in the public health and medical care field? I mean, I shared them with all the organizations representing maternal and child health, and with ASTO and the American Public Health Association. I also shared them. I also shared them with my 2 senators and my representative, and I asked them to ask Secretary Becerra to copy them on his response to our recommendations. You know, and I'm just wondering if any of you have had anything that you've done with those recommendations to make them visible, to make them sort of front and center in the conversation. Has anybody done anything with those recommendations? Magda.
Well, I just want to respond to that in a couple of ways. I think the first is that certainly in my relationship with the local level, with City Match and others, there has been a regular set of feedback and communication that will happen. And I think that if you were to go around for each of us that have connections to our colleagues, to professional organizations, whether that's global like Jeannie or local, as in City Match, that's one way that's a natural flow. And it's not just inform, but to engage. The issues that are found is that folks don't still get what SACIM is or have any evidence or proof that SACIM can leverage. And I think that that's beginning to change. So it's not just presenting the recommendations, but it is about putting it in the context of opportunity and leverage of what we can do that they cannot do. So it's a mutual help. And then my second point, and the last, is I think that the current structure, at least with the Data and Research to Action Work Group, because of its extensive participation from many, has allowed there to be a ripple effect, so that when we want to be able to give not just recommendations nationally, but serve as a sounding board for PRAMs, we're able to turn something around within 2 or 3 weeks and be able to consolidate that feedback and go forward. So I think that that there are ways not only within who we talk to, but how we can influence based on the deliberations that are here, that our structure of the 3 working groups gives us greater diffusion. I'd be curious to see what others have experienced.
Thank you. Lee, could you talk to us about the process, you know, and in visibility? And I assume that's why you raised your hand, to try to tell us actually how things work with the recommendations.
Sure, there are a couple of things. First, I'm not an explainer of the assistant secretary or given authority to speak for her on these issues, but as a political official who is relatively new in the position, I don't know that she is as fully briefed about the sort of operations and protocols that we use within the department for making sure that recommendations like this are reviewed within the department. So just as an update on the recommendations that you submitted, they were submitted to the secretary, as you know, and we provided that input to, or sort of acknowledgement back to you. We have since received feedback from the secretary to go forward and pursue a review within the department for across the agencies for application and interpretation of the recommendations that you're providing to the various agencies. that would be related to or be affected by the recommendations that you're making. So the process now that it has arrived in the office of the secretary, they have reviewed it and they have given us the sort of go ahead to then meet with, share this information with CDC, with NIH, with FDA, with CMS, officially to review and interpret the information that you've provided to us about your recommendations and how we might respond to that. So that's sort of the protocol and the process that we go through internally, where there might be opportunities or interest in having follow-on discussions as to the way we interpret this information that you've been providing and absorbing it into our future plans. We will then have meetings about that. And there will be some information provided to you in writing about that process. Also, I wanted to let you know from our end, as we have spoken in the past about this discussion of recommendations to the secretary and whether or not there's a report that's generated or not, we have been working internally with LRG, who's the logistics contractor, to compile the information that you're generating through the deliberations and meetings and the on the ground community-based input that you've been receiving, and the sort of history of the committee as it's proceeding along. We are incorporating into that document the recommendations that you're making and that you've made for purposes of generating some sort of a report that will be there for us to use when we decide to move on any policy issues that are related to your activities, so that they can then be used to say, these are supported by the advisory committee on this particular issue. I don't know if that's helpful, if you have other questions.
That's very helpful. And I would, just for Vanessa now is, I would really like a report in December about how things have moved along. I think we need sort of an evaluation piece of how effective are our approaches in terms of just getting information, whether or not they get accepted. But, again, I don't want the members to feel like it's just an exercise in futility. I want to, see some action and get some feedback of, all right, this is what you said just now really helps me. I wasn't aware of that process. And I think reporting back in December about more of what's happened in that process would really be helpful. Any other comments or questions about our recommendations? Magda.
Just a quick follow-up. One of the things that I'm mindful of, and I appreciate the tutelage I've received from Michael and Laura Kavanaugh and others over the years, is that there are other secretary advisory committees that relate to maternal and infant mortality prevention. And I'm curious about what the alignment is or the interplay between those within, say, where the secretariat is at MCHB or elsewhere in HRSA or elsewhere across HHS, because our purview is HHS, or even in EPA and others. So how do we, as a focused group on preventing maternal and infant deaths and promoting maternal and child health, how is our Secretary's Advisory Committee in alignment or able to leverage or be leveraged by parallel efforts that are going on within HHS or across government?
Well, I certainly can't answer that. Michael, can you?
I will try. Thank you, Dr. Peck. So I think some of that happens at the Bureau level, just thinking about just within the Maternal and Child Health Bureau, we have 2 federal advisory committees. So this committee, as well as the Advisory Committee for Heritable Disorders in Newborns and Children. So a big portion of what they see is newborn or oversee is the newborn screening process, making recommendations to the secretary for adding items to the recommended uniform screening panel. So there are obvious connections there. I think the other is the work that we are doing that is relatively new, and I'll talk a bit more about it when I share my update in a few minutes, but is our engagement of other federal partners, not only within HHS and the various operating and staff divisions within HHS, but with other agencies and departments across the federal government. And so I think that really is an opportunity for us to stay connected with what's going on in those areas. And then similarly, our staff serve as ex officio members on a variety of those other federal advisory committee meetings. So they take with them, we take with us those recommendations, that experience to those committees as well.
Yeah, thank you. Belinda, you had your hand up.
I did. I'm similar with Magda from the standpoint, I share this with AMCHIP as well as with the National Healthy Start Association, and I shared it within my own state. I mean, I think it was good to see that the alignment were things that were already happening and people were excited to see that our recommendations were in line. I think part of our challenge has been folks are in the middle of a pandemic and their bandwidth to just try to pick up another issue and try to move it forward has been the challenge. Because even in my own state, we have several strategic plans and lists of recommendations, but we're not moving up as fast as we would like to move, but that's because everyone is focused on the pandemic. And I do think they appreciated seeing the recommendations related to COVID, but when you're dealing with a workforce and community members and just individuals that are, again, living in a pandemic world, it has been a challenge to get people to elevate this as a priority. And I think it will come. I just don't think it will come right now because people are trying to just survive in many instances.
Yeah. Yeah, and actually that's one of the reasons. I mean, I agree that people are overwhelmed, and I wish they could walk and chew gum at the same time, but it's really hard just to walk, and this is sort of the chewing gum. And so that's our job, I think, is to get out some of these recommendations where those other organizations are stressed with the day-to-day activities. So I'm figuring out some way to do that. And I know we don't have, and MCHB and HRSA does not have a marketing to put out press releases for this kind of thing. I inquired about that when we put out those COVID recommendations, but I think we have to find ways to get it out there. It strikes me that there's so many articles recently about maternal mortality and infant mortality, and SACIM is never mentioned in there, or the recommendation are never mentioned. That we just don't have enough visibility to do that. And I invited a reporter to our meeting the last time. She never showed up, but I think somehow we have to get this into the press, that we actually have some good ideas, that we have some recommendations, things that could move the needle. And that's where I think it's attendant upon us as SACIM members to be a little bit more proactive in some of that kind of marketing and the education kind of framework mindset. All right, any other thoughts before we move on? Magda.
At the risk of spending all of my airtime in this session, I just want to specifically ask both Jeannie and Paul to respond, because we have recommendations that go beyond HHS in terms of environmental health and in terms of immigration. And I'm just wondering, what's the cross-fertilization specific to those recommendations that would allow them to grow some legs? And I was wondering if Paul or Jeannie have any perspective on that, or if, Michael, you have a sense of how in that populating other committees, there's a chance to be able to be very focused on the specific recommendations that are sitting there right now. And I know it's being farmed out, but I'm just wondering if there's anything further that can be done around these areas that transcend HHS.
Jeannie.
Well, I haven't viewed it as anything where we are in a position of advocacy from this. I'm in a position of advocacy for the other work and roles, but not in terms of what is happening here. So I'm happy that we're in an advisory position to the secretary and provided as such. And then I look at taking that same voice in other positions, but not anything where I would have thought, okay, SACIM said such and such. What are we going to do with that? And maybe that's something that Lee can help me understand better in terms of our role here. I take the same role and voice in my other organizations. In fact, that's what I was going to ask Dr. Levine about just World Patient Safety Day. That was a huge event. I don't know what we did in the United States about it. I know what the rest of the world did, and it was a focus on childbirth and infant mortality. I have no idea what the United States even did on that day, if anything.
Yeah, thank you. I mean, there's always this question about advocacy versus education. What I've been doing is just saying, this is what SACIM approved. These are the recommendations. Be aware of them, and incorporate them in your work as best you can, and not pushing for any particular policy as a SACIM member, but just say, here are the recommendations. I hope you're aware of them. They have some good information. Please use it. Paul, any questions or your response?
My approach is to strengthen accountability, to follow up on the recommendations, both within HHS and beyond. There's the potential that respect for the process becomes timidity. And these issues demand more than being timid, and certainly issues on the border. It's clear that HHS, as well as DHS and other agencies, are intensely engaged on the border. But that is not sufficient, in my view, for this committee. We need to ensure that we are holding HHS and its component parts and collaborative agencies to task to gauge the response. Now, the response may be not to take action, and that may be completely legitimate, but we have a responsibility to hear why inaction is been embraced, and why it may be the product of bureaucratic inertia or strong scientifically based or politically based logic. And I think that's our only protection, that the procedures and process under which this committee operates becomes a mask for inaction. And my hope, particularly given the expertise and commitment of the agency partners that we work with, that we will be able to gauge both actions taken and actions not taken.
Thank you. I appreciate that. All right. Well, thank you all for this discussion. This has been very helpful, and I hope it's helpful to you. So now we've got the next 45 minutes or so to get some federal updates, which I think are also going to be quite interesting because a lot's going on. So Michael, Dr. Warren, I turn it over to you.
Thank you, Dr. Ellinger. Good afternoon, everyone, or good morning, depending on where you're joining from. Just very briefly, a few updates from the Maternal and Child Health Bureau. We are rapidly winding down fiscal year 21, which will end in 9 more days. And so we have been looking at ways to make sure that we leave no resource untapped and make sure that we maximize the use of those resources. And as we have the opportunity to do that, really making sure that we align with the priority specifically around equity and the interests of this committee. So I wanted to share a few updates. We actually did a pretty broad public release of these last week, but in case you did not see them, it was about a $350 million release that was announced last week. $342 million of that was for the Maternal Infant Early Childhood Home Visiting Program, or MICV. Those awards went to states and jurisdictions. Those are formula awards and support voluntary evidence-based home visiting in those states and jurisdictions. They identify the communities where they would like to deploy those services, and those funds are now available to them. Also included in that $350 million rollout were supplements to our Healthy Start grantees. So these were competitive supplements that existing Healthy Start sites could apply for. One set of those supplements was related to increasing the availability of doulas. So we made 25 awards for $125,000 each to healthy sites across the country. And then we also made 21 awards to support the development of infant health equity plans. Those were 21 awards for $80,000 each. And those awards really will start to be a stepping stone to our further work that we've mentioned to you before around achieving equity in infant mortality by 2030. We know, for example, that in the Healthy Start sites as they currently exist, if you map out all of the excess infant deaths, those are the deaths that are in the gap from where we currently are to where we need to go to get to equity. Among Black infants, 50% of those excess infant deaths are in counties that are already served by a Healthy Start site. And so we really have an opportunity to leverage Healthy Start to accelerate that work to getting to equity in infant mortality. And so the goal of those infant health equity plan supplements is to help them engage partners in the community that have not previously been engaged, particularly as we think about social and structural determinants of health and how they might incorporate that work into the work of their community action network as part of their Healthy Start site. So really excited to see those awards go out. Again, trying to maximize use of those resources so that they aren't unspent, and also make sure they're maximally aligned with our interest in equity. The last part of those awards that went out was a supplement to 10 states, $60,000 per state, to enhance the quality, timeliness, and accuracy of their data related to maternal health. So these were supplements to state block grant, MCH block grant recipients who get our State Systems Development Initiative or SSDI funds. Those funds have been around for a long time and help build basic MCH data capacity in states. This was additional funding to supplement them specifically around maternal health data. So collectively, all of those accounted for about $350 million that was announced last week. And we're really excited to have those funds out the door. In terms of looking ahead to FY22, which will start in 9 days, excited that there are a number of efforts in President Biden's budget that relate to the work of this committee, both in the space of infant and maternal health. And so just want to highlight those for you. There's a $5 million increase for the AIM program, the Alliance for Innovation on Maternal Health. There's a $30 million increase for state maternal health innovation programs. These are grants to states to support the convening of a maternal health task force, to leverage data that comes from maternal mortality review committees, from vital statistics, from other population data sets to be able to identify the areas of greatest need and then implement innovations in response to that. There's a proposed $1 million supplement to the maternal mental health hotline. This is something that was new in the current year budget that is out for procurement as we speak. There was $3 million allocated for that to be a 24/7 national level hotline. And so the president's budget contains an additional $1 million proposed for that. There are new initiatives, $25 million proposed for a pregnancy medical home demonstration project, $5 million for implicit bias training grants for health providers, and $1 million for a National Academy of Medicine study. So that's the proposed president's budget for FY22. As you all know, if we don't have a budget passed by September 30th, we'll be under a continuing resolution. So we are watching for developments there. The last thing I'll mention very briefly is the Infant Health Equity Initiative that I've mentioned. This is how do we get to equity by 2030 and eliminate those excess infant deaths to truly get to equity for all infants. We have engaged a contractor from Milwaukee and Region 5 to help us with initiative planning, basically helping us to understand within existing resources, what could we do? And then if additional resources were made available, what paths would be most effective for us to pursue. We've convened federal partners, initially partners within Health and Human Services for the first meeting, and the second meeting, which was just held last week, also started to engage partners outside of HHS. So for example, HUD And those have been very productive meetings, lots of good information sharing about what folks are currently doing, what folks are planning to do in the next fiscal year, and how we might align and leverage the investments across HHS there. And then in early November, we'll be convening a group of stakeholders in Region 5. So HHS Region 5, 6 states, Minnesota, Michigan, Wisconsin, Illinois, Indiana, and Ohio. Historically, the highest rates of Black infant mortality in this country, as well as the highest absolute gap between Black and white infant mortality. The states in those regions approached us and asked us to think about how we could support their work in achieving equity in infant mortality. So for the last year, we've been engaged with them in a learning series looking at root causes of inequities in infant mortality. We had planned to convene an in-person meeting in Chicago in the second week of November. That's now moved to a virtual meeting. But where state Title V teams, Healthy Start grantees, community partners, state leaders, folks that the state identifies as wanting to come together can come together to talk about that commitment to get to equity by 2030, and for us at HRSA to better understand where our opportunities are to support them. So we can report back to this committee when we meet in December about that Region 5 meeting. And that's the update for us. Thank you.
All right, I'm going to hold questions because I'm sure there are a bunch until we have all of our presenters. So hold on to your questions, and we'll have some time at the end. Sheila Williams.
I'm here.
Good. I saw your picture, so I know you're there.
Thank you. So I'll be giving some updates today for the Bureau of Health Workforce. And next slide. I don't know who's advancing the slide. Thank you. So real briefly, the Bureau of Health Workforce, our mission basically is to improve the health of underserved communities and populations. And we do this in 2 ways. We do this basically by strengthening the health workforce and then connecting that health workforce to those communities that are in need. And so we have grant and direct service programs that are funded through our Bureau. And we really seek to impact every aspect of a health professional's career, from education to training, as well as to service. And so we do this through, trying to be flexible and innovative in our response through our programs. And we really look at education and training in the community. So one of the threads that runs through our programs is making sure that individuals are educated and actually trained in the communities where we want them to serve. So there's a lot of academic and community partnership that happens in our programs. And then, ultimately, we want to make sure that the distribution of the health workforce is reaching those areas, those rural and underserved areas that we want to make sure have access to care. And so that's another set of our programs that we have. Next slide, please. So to look at our focus areas in, the last year and in the upcoming year in 21 and 22, we're really focusing, on health equity. As we emerge from COVID-19, we're looking at 2 priority areas for the Bureau, and those are behavioral health and community health. And they really align very nicely with the department's priorities for COVID-19 response, maternal and child health, health equity, and behavioral health. And as we emerge, from the pandemic, 2 cross-cutting themes for us have been provider resilience and diversity and health equity, which is where our maternal health, some of the programs that we have really looked at for maternal health, improving maternal health, reside. And so we have really had to really think about our policies and our program development as we've gone through COVID-19. It's presented us with some unique opportunities and some unique challenges. And so can go on to the next slide, I'll talk a little bit more. So in BHW, which, we love acronyms, so just use the acronym BHW, our program aims really, these are the levers, these are the areas in which our programs really try to impact. And the first is access to care. So through the workforce, we want to make it easy to get care. And so we have to have that available workforce that is in tune with the community, that understands the community, and that is in those types of facilities where, regardless of your ability to pay, you can receive care. The next is supply. And so we really look to balance the supply with the demand for healthcare. And so we really start looking at things like adequacy, and we look at expanding our programs, so expanding a profession. So for instance, we have expansion programs in behavioral mental health, expansion programs in nursing. So really, I think as we move forward, there's going to be a lot more attention and more programs coming out that really are ramping up the supply, especially as we deal with the after effects of COVID. And then we have a distribution. We have programs that are focused on distribution. And basically, we really, again, try to do that balancing act between supply and demand and make sure that there's adequacy. We know that there's some maldistribution that occurs. Sometimes it's regionally, sometimes it's particular states and in particular professions. And so we constantly are looking at that data. We do a lot of that work through our National Center for Health Workforce Analysis and through our projection and supply and demand reports. And then quality. So in a lot of our education and training programs, we're looking at how do we improve the quality? How do we look at evidence-based care? How do we promote that patient-centered care, culturally competent care, and make sure that we have good, outcomes? And because we have over 40 programs, one of the things that we've been, very intent on doing is where we can really aligning our programs and integrating them so that we are not just looking at one piece of this, but we're looking at all of these things in connection with each other. So next slide, please. So I'll just give you a snapshot of some of our programs in terms of diversity. So some of the ways in which we look at increasing diversity in the workforce is we look at trying to increase the pipeline. So individuals coming into the health professions education. And so I'll just give you a snapshot of some of the ones that have in their statutes, actually, they have diversity goals and purposes. And so first one I'll talk a little bit about is the Area Health Education Centers program, which many of you may be familiar with. But basically, that's a program that operates, we have them in just about every state. And they really aim to improve that academic and community-based partnership. We do a lot of longitudinal training in building the pipeline of individuals from underserved communities. So individuals from rural backgrounds, individuals from disadvantaged backgrounds, minority backgrounds. And so that really is a program that has been around for a while. And we continue to invest in those programs to get people into the communities where we want them to serve, get the experience, get the education, and longitudinally. So we want them to go back over the course of their professional education and serve in these communities. So they're very familiar with the patients there. They're very familiar with any of the cultural issues, linguistic, and all of that. The next is the Scholarship for Disadvantaged Students program. And this is a grant program as well. And this program funds health profession schools to provide scholarships to disadvantaged students. And so disadvantaged students are those that have economic need. And so they meet criteria that have been established for financial aid, as well as educationally, those who are educationally disadvantaged as well. So they come from a background in some ways that has not necessarily prepared them the best, or they've had to overcome some obstacles in order to gain admissions into health profession school. And then we have the Health Careers Opportunities Program, which is another pipeline program, and it's an earlier pipeline program, but it's one of the programs where we have a lot of flexibility. And so as we're looking at the pipeline, we're also beginning to look more at non-traditional sort of pipeline efforts. So some of these programs will deal with individuals who are in high school, through their college, through undergraduate, and then getting them into a professions program. But we're also looking at and have been funding more of non-traditional students as well, people who want to, who maybe are in some aspect of healthcare or support, health support services, and want to have some career advancement and build a career in healthcare. So that's another program where we really key in on the disadvantaged background of individuals, as well as individuals who are URM. And disadvantage could be meaning a lot of things. The areas, where you grew up in terms of opportunities, language barriers, first generation college. So there are numerous ways in which individuals identify as from a disadvantaged background. We have the Centers of Excellence program, which has been around for a while, and this is another grant program that focuses mostly on the institutions and developing and strengthening their capacity to diversify the health workforce, to deal with health disparity issues, to have to help the students gain experience in research on health disparity issues. Also, it's specifically for underrepresented minorities, and it's in medicine, dentistry, public health, pharmacy, behavioral mental health, and veterinary medicine.
My way out. Okay.
I think someone needs to mute their speaker. Additionally, we have the Nursing Workforce Diversity Program, which is a Title VIII program specifically to improve diversity in the entry-level nursing or registered nursing. And so again, another pipeline program that really helps individuals to be prepared to gain entry into the health professions. Next slide, please. I'll talk a little bit too about our loan repayment and scholarship programs, because these programs, even though they're not always considered a pipeline unless we're talking about the scholarship aspect of them, there is a lot of, we find that we have, it supports diversity in the health workforce in a couple of ways. On the scholarship side, a lot of times this individuals from disadvantaged backgrounds have some issues funding their health professions education. And so the scholarships programs are really important because it provides that, that financial support, and it also allows them to serve in underserved communities by agreeing to a service obligation. And so if we look at that in the loan repayment programs as well, which are very important for us in terms of retention in underserved communities. We've done some things with some additional monies that we got in 21 with some of the American Rescue Plan, 200 million. We really looked at how we could improve and how we could ramp up the supply of maternal care providers. And so we dedicated 10 million for women's health, nurse practitioners, obstetrics and gynecology nurse practitioners, certified midwives, and OBGYN registered nurses. Additionally, we added in the National Health Service Corps, Student to Service Loan Repayment Program. Nurse midwives are a new eligible discipline as of 2021. Important to note when we talk about diversity as well is that 15% of NHSC physicians are African American, and 15.8% are Latino. And so those are compared to, there's only 5% of physicians who are African-American and 5.8% of physicians who are Latino in the general population nationally. So we know that these programs do support diversity in the workforce and diversity in the pipeline as well. Next slide. A new program that we funded in FY21 is the Primary Care Training and Enhancement. We call it PCTE, a community prevention and maternal health program. And that program had about 16 million. We funded it this summer. And basically it trains primary care physicians in maternal care, clinical services, or population health, and really to improve, again, aiming to improve maternal health outcomes, and then to increase maternal health care expertise, and the number of primary care physicians that are trained in enhanced obstetric care in rural and underserved. This program had two training tracks. One was in community prevention track, and the other was in a primary care obstetrics track. So they have different, two different tracks, but different aspects of maternal care. Next slide, please. As I mentioned earlier, our National Center for Workforce Analysis is very involved in projecting the workforce so that we can contemplate what kinds of changes we're seeing or expect to see, so we can really be prepared to develop policies and programs to address what the anticipation in changes in the workforce and the needs of the population. So by 2030, we project that the supply of women's health service providers, we project a 7% decrease in the supply of obstetricians and gynecologists, but we other providers such as certified midwives. We project a 32% increase, an 89% increase in women's health nurse practitioners, and a 56% increase in women's health physician assistants. We also anticipate a higher demand in full-time women's health service providers, including all of those mentioned above. So we're expecting increases in the demand as well. And so, and I want to say, as we look at these numbers, we don't see uniformity. So we do see in some states and regions, you have an oversupply, and in other states and regions, you have an undersupply. And that can range anywhere from an undersupply of, only having 56.8% of what's needed in a state or region, all the way to having 157% of the need, the demand being met in terms of the availability of workforce. And so I'll stop there. And that concludes my update for the Bureau of Health Workforce in HRSA. Thank you.
Thank you very much. Now let's go on to Julia Bui.
Thank you, Dr. And hello, everyone. Thank you for your important work and for the opportunity to join you today to share updates on behalf of the HHS Office of Minority Health. I'm going to highlight a few of our fiscal year 2021 grant initiatives that may be of interest to this committee beyond the efforts that Dr. Levine shared about earlier. Our initiatives are all aligned with OMH's mission of improving the health of racial and ethnic minority populations through the development of health policies and programs that will help eliminate health disparities. And they also reflect the enhanced focus and priority on equity across federal government that's been underscored today by our HHS leadership. While these initiatives don't have a direct focus on infant mortality, I think that they may address some relevant and cross-cutting issues and upstream factors. You can find more information about the initiatives that I'll talk about today and our other OMH initiatives on our website at minorityhealth.hhs.gov. So the first initiative I'd like to share about is the Framework to Address Health Disparities Through Collaborative Policy Efforts initiative. And the focus of this initiative is on policies that create or perpetuate health disparities by contributing to structural racism. The initiative is comprised of a coordinating center and demonstration project sites, and together they'll aim to demonstrate the effectiveness of a methodological framework in supporting the assessment and identification of policies that may create or perpetuate health disparities by contributing to structural racism. And they'll also modify, develop, and implement policies to improve health outcomes. Another initiative is our Minority Leaders Development Program. This is a program that will support a fellowship program at HHS for early career individuals to provide training focused on health equity issues, and also to help develop the skills and competencies necessary for federal leadership. So this program is expected to support efforts to promote diversity in senior positions within HHS agencies. The third initiative I want to highlight will establish a Center for Indigenous Innovation and Health Equity. The center will support efforts including education, service and policy development, and research related to advancing sustainable solutions to address health disparities and advance health equity, specifically in the American Indian and Alaska Native and Native Hawaiian and Pacific Islander populations. And then finally, our Accessing Social Determinants of Health initiative, Accessing Social Determinants of Health data through local data intermediaries initiative, will seek to demonstrate whether existing local data intermediaries can facilitate community stakeholder access to and utilization of integrated community level social determinants of health and health data, and then increase community stakeholder skill and capacity to use and apply that data to address health disparities among racial and ethnic minority populations. So our grant initiatives span a number of areas of focus in addressing health disparities and promoting health equity, from systemic issues and policy impact to public health workforce development, to access to and use of data, to identifying and disseminating effective culturally centered approaches, all areas that I think likely align with discussions that the committee may have as it relates to efforts to improve maternal and infant health outcomes, to center equity, and to address disparities. The awards for these initiatives have not yet been announced, but we anticipate projects to start September 30th. And again, you can find the latest information on our website at minorityhealth.hhs.gov. Thank you very much for your time. I know that Joya is a member of this committee and is a great point of contact should there be any questions, or we can provide any more information moving forward.
Great, thank you. And now let's open it up for questions. And I see Steve Calvin has his hand up.
Yes, thanks a lot. And thank you for all three of the presentations. Captain Pradia Williams, as a recipient of a National Health Service Corps scholarship back in the late 70s and then service in the early 80s at a National Health Service Corps site, I appreciate your work a lot. And it's really heartening to see that there is support now for nursing scholarships. And I've been aware for a while too, and I know Jeannie Connery has as well, that the workforce numbers for physicians will be dropping for a whole variety of reasons. But happy to see that the nursing options are increasing, including the nurse midwifery numbers, and then also the women's health practitioners, and I think even the physician assistants. The question I have, how is the word getting out to potential scholarship recipients? What kind of engagement is HRSA doing? I'm sure there's some through the schools. And then the second question is there any support for the specific training programs, certified nurse midwife or women's health practitioner programs?
So this is Sheila. So in terms of how we get the word out, so we've got different mechanisms. We actually have a presence on social media because these are direct service programs. So we also get it out through the schools and through associations, student associations, healthcare associations. But we also have a direct presence on social media where individuals, that information is shared. We share it with the schools. We share it with For instance, a lot of the word also gets out through the facilities, because it's these programs are a tool for healthcare facilities and providers to get clinicians in their sites. And so, there's those. We also have quite a few virtual job fairs. And so we have a workforce. We actually have a presence online for a workforce connector, which helps individuals to identify positions through, National Health Service Corps and Nurse Corps, identify Nurse Corps sites. And so those are some of the ways in which we get that information out. I think your second question was, how do we provide support to?
Yeah, I think to the schools, I mean, to the programs. I know it's more of an individual thing with individual students. And I'm just wondering if HRSA has ever thought of, even in growing the number. I think midwifery programs, there might only be like 32 or 34 of them around the country. So just a question, a general question.
Yeah, as we look at, so it really just depends on the authorities we use, but as we look at expanding, that is where you get a lot of grants. Our grants do have components to them on the grant side, not the direct service side, through the loan repayment and scholarship. But we do a lot of grants as well to the institutions to strengthen their ability to recruit and to train. And so I foresee, more expansion programs in terms of just revving up the numbers and supporting the infrastructure for the actual nursing schools to increase their numbers. And so that's institutional capacity. And so those are grants that will, we do provide some institutional grants, but even in those institutional grants, there's a portion that goes directly to the trainees, if you will, to enable them to partake in training that's in the rural and underserved communities.
Great, thanks so much for your work.
It doesn't all go to them.
All right, thank you for your work.
Thank you.
Hi, I think maybe I'm not sure if Ed said that I could go, but I'm going to go. Thank you. Thank you so much for the presentations. And Juliet Bowie, I'm really excited to read up on OMH that Joya just sent out the link, especially on the Indigenous health concerns, the program that's being made on Indigenous methodologies. And then Captain Sheila Radia Williams, thank you. I am so excited to hear what is going on in your department as well. And there was a question that one of the attendees asked, which I also had a similar question, but the plans that you have to expand the PCTE CPMH model that is now being used for primary care physicians, and I'm assuming this is probably likely in rural areas, but is there a similar program that will include emergency department staff? And then a second part of that is for the complicated patients in these rural communities, especially, what kind of linkages will these primary care physicians have through this program to use their knowledge to help serve our vulnerable women and infants? Thank you.
You're welcome. So so I think your first question was around emergency department. And so I think, the programs do focus in on, residency training and also some advanced training and, fellowship training, and includes family medicine and primary care. So, and some of these areas, they are at smaller, to your point, maybe at some rural and smaller facilities. I don't, and I could get back with you on this, I don't recall seeing anything specifically for emergency medicine, usually, but I could certainly check in that. Some of our grants, because they are affiliated with smaller, rural hospitals, sometimes there isn't an emergency medicine, piece to that, but not always. So I can check into that to your specific question. And I think the second part of your question was in terms of linking them to other, I guess, academic
Right. The
academic health centers or.
Yes, like the maternal infant kind of like information that they'll be receiving as primary care physicians in their roles, then how do they manage complicated patients with this information?
Okay. Again, I'll have to get back to, I think each one of them came in with their specific proposal as to how they, would, put these together. And I'm sure there were some requirements in there, but I can certainly get you more detailed information about that particular program and how that is developed and aligned for the complicated patients.
Thank you.
Ms. Pradier-Williams, since you have the floor, I have a question myself. In our state here in Minnesota, we have about 250 foreign trained physicians who cannot practice because they have not been able to get residency slots. And they're usually from immigrant communities and are willing to serve in primary care areas. But there's so many structural barriers. And my guess is that other states have the same issue. And with new immigrants coming in and refugees coming in, it seems like a resource that HRSA should be looking at to figure out some way to get them to be able to use their training and their expertise and their connections with the communities. Is HRSA looking at foreign trained physicians and work that can be done to help them get into clinical practice?
Basically for our grant programs, the trainees for our grant programs usually have to be citizens or if they are permanent residents of the United States to be trainees. I know that I don't think there's any particular one specifically focused on foreign trained physicians and specifically trying to get them into into any of our training programs. Some of them may be because they may have status to be part of our training. But right now I can't think of a program that specifically has that as its aim. But I hear what you're saying. And we could certainly take a look at that. I think that would need probably some sort of legislation or some sort of statute that specifically points to that, because I've been scouring Title VII and Title VIII, and I don't, nursing or the medical side for our programs, and I have not seen a program that is specifically targeting, foreign trained physicians.
Also, with COVID, most health resources and training and licensing is on a state basis. It's all state focused. But with COVID, there are a lot of trans-state, interstate activities. There are coalitions where nurses can practice in multiple states and physicians can practice in multiple states. And that has, is HRSA looking at that in terms of how can we actually find out what benefits that plays in dispersing limited resources, or when COVID declines and people start putting up their borders, walls in their state, will we lose some opportunities that we are getting right now?
Yeah, I think in BHW anyway, we have, when we first, when COVID really became an issue in terms of us being able to train, and, we were looking at our programs and how our programs would be able to continue. We did see a lot of, we saw these nursing compacts get even stronger, and really looking at being able to have, the nurses train and practice and be licensed in multiple states. And so we certainly encourage that. Those are things that are taken up at the state level, but we certainly encourage it. And, we think that it only strengthens the workforce. I think there's some things from the regulatory side in terms of, scopes of practice and things like that that vary. And so sometimes those things can play a part. But we did see some, relaxing of some of that in terms of, entering into compacts, not just in nursing, but in other professions as well. And so, from a workforce perspective, we certainly encourage it and promote it. And we through some of these state associations that we work with and licensure groups that we work with.
Yeah, well, I hope somebody's collecting
Encourage
what we're
something that we encourage.
Janelle.
Thank you. This is probably my last question, but it's a discussion that we've had a number of times in the health equity work group, where we talk about diversifying the workforce in terms of different kind of birth workers, including doulas, midwives, professional midwives, physicians, the whole perinatal force, but also diversifying the color and the ethnicity and the language among our workforce. And so the funding that is going to, especially nurse midwifery schools or different programs, even for physicians, is there some sort of tracking of upon entry into school that the school has X number of self-identified minority students, but then that cohort moves through and they graduate X percent? Because that is something that would be really important to have to help us understand what's going on and if there are issues that need to be addressed. Because anecdotally, in the nurse midwife forums that I'm a part of, and also Pat Loffman, who will be speaking a little bit later, it is nearly every day where we get email conversations from students of color talking about the difficulties they're facing. Thank you.
Yeah. And so specifically with our diversity programs, where we have diversity actually in the statutes, we will collect some of that information on the application side. So when an institution is coming in, there might be priority points or something that are awarded based on them meeting certain benchmarks in terms of URM, in terms of disadvantaged status, in terms of rural and coming from a rural and underserved background. We also collect in our performance measures. We're able to track and collect by program. We're not able to, it's collected on an individual level, but we can't identify, we certainly don't want to identify individuals, but we do know, and I think what you're kind of getting at is, are they making a commitment and are they graduating them, right? So what is, so there's one thing to have enrollment, and then we look at also graduation rates, and we do look at trends for that. Something new that we have this year, and it's not forward, it's not externally facing right now, but our grantees actually have a scorecard. We just developed a scorecard. And so they're able to look at certain metrics and how they are comparing to others, to other grantees, and how they're comparing on a in general. And so they're able to gauge their performance in those sort of metrics, like the diversity of their trainees and how well they are doing in terms of retaining them, supporting them, and graduating them.
Well, great session. Thank you. There's a lot more things that need to be talked about. So, but thank you to Dr. Warren and Captain Pradia Williams and Ms. Bowie. Really good information that you brought forward. And we're right at time to take a break for 15 minutes and come back. And we've had an interesting half day so far, or a quarter of a day, I guess, since we're 4 hours. First 2 hours were really interesting. I'm sure the last 2 hours are going to be just as interesting. So come back at quarter after the hour. We'll see you then. Welcome back to everyone. I hope you got refreshed and got your coffee or your tea or your water or whatever else you need to stay hydrated on this last day of summer. Certainly in the first half of today's meeting, we heard a lot about workforce, and we heard a lot about data, and obviously all in relationship to moms and babies and infant mortality and maternal mortality. So the next half of our session today are going to be really focusing on again, some more workforce issues, some data issues, and certainly equity issues. So I'm going to turn it over for our first panel, turn it over to Belinda Pettiford. Belinda.
Thank you, Ed, and thanks everyone. So the Health Equity Work Group, we're excited to share today's presentation with you all. As part of our recommendation to the Secretary, race concordant care has been identified as a factor in potentially reducing disparities in birth outcomes. It has been discussed for years and has been actually achieved in some communities. If you look into our history, it has been available in the past. More recently, this issue was further discussed in the Health Equity Work Group of SACIM. It is also connected to SACIM's recommendation to the workforce being diverse and reflective of the communities that are actually being served. The Health Equity Work Group's focus on race concordant care is based on relationship building that impacts access to and utilization of care. Communities should have the option to have the provider of their choice. Even though the research is just beginning, several articles have been shared and they're in your briefing books. And if you're a member of SACIM, we hope that you will take time to review them. As we approach race concordant care today, we consider the following. The majority population already has access to race concordant care. They're able to select from a host of providers that look like them to schedule all types of appointments related to their health care. Race concordant care is not segregation. It's providing individuals options so that they will feel most comfortable in their care setting. We are aware that there are pipeline challenges, and we will hear more about them today. Conversations need to also occur with individuals on what their specific needs are in regard to having respectful care. Patient satisfaction processes are important, and we feel like they should be conducted when at all possible anonymously or by a third party. If you like your provider, you're more likely to keep your appointments and share information that impacts your plan of care. BIPOC populations would like access to race concordant care as well as the majority population who already has access. As you will hear today, one option for strengthening our pipeline is through increasing utilization of midwives as well as doulas. This is one of the areas that we will discuss. If I can get the next slide, please. So for today's session, we're going to cover some of the following areas, as you can see on your screen. We'll provide an overview of race concordant care, importance of respectful care. We'll share some examples of race concordant care efforts, as well as discuss ways to strengthen the pipeline and increase access for BIPOC populations. And at this time, I would like to introduce you to our two speakers for today, because we're really excited to have both of them join us. First, we have Dr. William McDade. Dr. McDade is the Chief Diversity, Equity, and Inclusion Officer, Accreditation Council for Graduate Medical Education. So thank you, Dr. McDade. Right after Dr. McDade speaks, we're happy to have one of our Health Equity Committee members, Patricia Lofton. Patricia is a certified nurse midwife. She's chair of the Bylaw Committee for New York Midwives. She's also a member of the New York Department of Health and Mental Hygiene, and also serves on their Maternal Mortality Review Committee. So at this time, I'm going to turn it over to Dr. McDade, and both of them may introduce themselves further, and we'll take the time we're going to hold our questions until the end, because we want to make sure both speakers have sufficient time, but please start entering them in the chat and we'll be watching the chat. So Dr. McDade, thank you for joining.
Thank you very much. Thank you very much. I'm going to share my screen and get started. So the idea of racially concordant care is exactly as Belinda described it. It's care by a provider who shares your same racial ethnic identity. The care provided by a physician who shares that same racial ethnic identity can really fall into two categories. And the question is to why is it that we receive our care in this way? Do individuals seek out physicians of their same race and ethnicity? And the answer is yes, they do. Because of comfort, familiarity, because of language concordance or communication, because of psychological safety, physical safety, because of trust, respect, because of a shared worldview or proximal location to where they live. All of these reasons might be why people choose a provider who's of the same race and ethnicity. But the opposite question is, why do physicians who disproportionately care for people of their same race and ethnicity choose to do so? And part of it's from a race-conscious professionalism perspective, where there's a sense of doing societal good, recognition of a unique role that they may play, and job satisfaction. One of the most satisfying moments I had in my life was taking care of my kindergarten teacher. I think there's an idea that when you give service back to the people from where you've come, you've actually done something as a member of a historically marginalized group. It identifies the population that you're served, and it gives you a sense of belongingness. And we find that when physicians actually leave one city and move to another, they often relocate in communities that have a very similar racial composition. There's also the idea that physicians practice disproportionately in this model because of discrimination or racism. That is the inability to take care of people who aren't of their same race and ethnicity, or elitism. The schools that underrepresented physicians attend are often of not the elite category, maybe the majority of them actually from historically Black colleges and universities with advanced degree programs. And so there may be some elitism involved in the selection of candidates to be in certain environments. But we understand that with racially discordant care, that Black mothers are mistreated in our health systems. And across race and ethnicity, including Asian Pacific Islanders, Latinx, Black, and white mothers actually reported experiencing discrimination during childbirth. About 1 in 10 women reported being spoken to disrespectfully by hospital personnel in a study done back in 2019, the National Partnership of Women and Families. 10% reported rough handling by hospital personnel or being ignored after expressing fears and concerns. And Black women were more likely to experience this unfair treatment and discrimination in the health system than were white and Latina women. So the idea that that trust is earned, that is, that mistrust is earned, actually comes into play in the treatment of women who are there. Now, this is an important paper from our colleague at Johns Hopkins, Lisa Cooper, and her group, really suggests that patients see themselves and their physicians, and that racially concordant care allows physician patients to find those common personal beliefs, values, and communication. And the perceived personal similarities associated with higher ratings of trust, satisfaction, adherence to medical advice, and that race concordance is the primary predictor of this perceived ethnic identity. Now, the benefits of racially concordant care are that it really addresses the unfortunate reality of how we trust in American society. And that we mentioned before that the intention to adhere to medical advice is heightened in these situations, and that patient satisfaction is better when there's historically marginalized physicians and groups and providers who are concordant. And that in fact, there are improved clinical outcomes in certain categories, and we'll talk about that in a second. That you have improved clinical access to individuals who would rather forego care than to receive it in an environment that dehumanizes them is one of those driving factors that causes people to seek these concordant relationships. And the idea is that if I have to go to a doctor where I'm disrespected, where I'm humiliated and discriminated against, I'd rather not have care. And that really results in some of the disparities that we actually see among minoritized populations. And this goes to the idea of vaccine hesitancy, even in the COVID situation. This is a paper by my colleague Fatima Cody-Sanford, who really said that it's not just the historical racism that's taken place in medicine that we all recognize, the J. Marion Sims experimentation and surgery on enslaved women, Henrietta Lacks cells being used without her family being compensated or acknowledged, the Tuskegee syphilis experiment that was done by the Department of Health Services for many years, withholding treatment for a disease that could be treated. It is in fact everyday racism experienced by Black and brown communities, historically marginalized communities, that really is the core of what the problem may be in trying to reach those who have chosen to be unvaccinated from racial and ethnic minorities. So there's a hazard, though, of depending on racially concordant care to eliminate health disparities. And the hazard is that these discriminations aren't just medical, they're social. And these social determinants of health factor in along with that access question to concordant providers. And that these social determinants of health cross over a variety of areas. They include lack of access to healthy food and food practices, inundation with ultra-processed foods, community and interpersonal violence that takes place, and then lack of access to green space for play and exercise, environmental conditions that may include pollution and substances that make the substance toxicity that impair health, housing insecurity, poverty and wealth gap, allostatic load, the adverse childhood events, inadequate transportation, neighborhood disinvestment, over-policing, residential segregation, structural racism. Those are all factors that interplay with access to healthcare that contribute to inadequate health. The political determinants of health, as our colleague Dr. Dawes would say, that also factor in here and recognizes how inequitable policies, politics and regulation and laws have impaired access to care and contribute to health inequalities. So fixing the workforce isn't enough. And that's what this shows. This is the data from the ACGME that shows the number of, or the percentage of underrepresented minorities in our healthcare programs across the country as a function of race and ethnicity. And what you'll see there in the green bars are the African-American percentage of residents over the last 15 years. And we see that the number hasn't changed a bit. Latinx individuals hasn't changed significantly either. And so if we're going to increase the percentage of people who are of the races and backgrounds of those historically marginalized groups, we're going to have to do something different with respect to workforce, as you discussed earlier today. We simply have not graduated enough Black, Latinx, and Indigenous physicians in order to do this over the last 40 years. We have to make sure that all physicians understand the importance of cultural humility in delivering care to patients from historically marginalized groups. And so that's what we're doing at ACGME. We'd like to improve healthcare and population health by enhancing the education of resident physicians through accreditation and education. We also have now defined diversity and inclusion as targets for all residency programs and fellowships that we accredit, and we credit almost all of them in the country. And the thinking is, let's educate physicians who are more likely to serve underserved patients and locate in minority communities so that we can increase healthcare access and improve trust, communication, and outcomes for those most at risk for health inequity. And so this is just a map showing the practices in cardiology in Chicago with blue dots for every cardiology practice. And what I'll show you is that on the south side of Chicago, a very largely African-American community, you'll see that there's a big gap with respect to where physicians practice. There's a community called Inglewood here. You'll see the same thing on the west side of Chicago, where there's another very large African-American population that's totally absent of cardiology practices. The New York Times went to Chicago and looked at this and found that the life expectancy for someone in Inglewood, which is where I showed you before, is 30 years less than the life expectancy for someone who lives in Streeterville. And you'll notice an absolutely inverse relationship between the Black population in Inglewood and that with respect to Streeterville. So race is still a very important factor with respect to where physicians practice. And what we find is that the geographic co-location of physicians and disease is part of the problem in providing access. People aren't leaving their communities to receive the care that they need. So if you look at other data on residential segregation and the available primary care physician, you'll see that the odds in being in a primary care physician shortage area are about 67% greater if you're in a majority African-American zip code. And that as the degree of segregation increased in your zip code, the odds of being in a primary care physician shortage area also increase. This really is the essence of it, that you don't leave your communities in order to seek care. If you look at dentists, this is a paper from Health Affairs that suggested that racially concordant care happens even when dentists don't practice in underrepresented communities. And that if you look overall, that 54% of an underrepresented minority dentist practice is in underrepresented minority individuals. That individuals come and seek this care as if they're in their communities and if they're not. So even aside from the proximity argument, there's also a tendency to go to physicians of your same race and ethnicity, and this is probably due to some of those other factors that we talked about, such as trust. This is a report from the U.S. News and World Report who looked at the procedures done in cardiovascular, cancer, and orthopedic procedures. And from 2012 to 2018, Blacks receive 67,000 fewer orthopedic procedures. That is in part due to the fact that there's not co-location of physician with the disease burden for African Americans. And so people would rather forego their operation than to go to a non-concordant care physician. And we see that's the detriment of the well-being of African Americans. So if you want to find out who's going to practice in an underrepresented community and who's going to serve underrepresented patients, ask a first-year medical student. So what we see here is over 60% of first-year medical students who are African-American say that they're going to practice when they graduate in an underserved community. Well, after 4 years of medical school, do we beat that out of them? The answer to that is no. That in fact, still African-Americans lead the group of saying that that's where they're going to practice in an underserved community. Still over 55%, and Native Americans still around 50% say that that's where they're going to practice when they graduate from medical school. And so this is data from the Cambridge Health Alliance, which says that your odds of taking care of an African-American patient, if you were an African-American physician, compared to taking care of an African-American patient, if you are a white physician, are about 23.25 times greater. If you're a Latinx doctor taking care of a Latinx patient, compared to a white doctor, you're about 19 times as great to an odds. You have that great an odds of seeing a patient of your same ethnicity. If you're an Asian physician seeing an Asian patient, you're almost 26 times more likely to see an Asian patient than if you were a white physician seeing an Asian patient. This is data from Peter Bach, published in New England Journal of Medicine, that says in primary care, a Black physician was almost 40 times more likely to see a Black patient than was a white physician to see a Black patient in primary care. So it's not that we're making people work where they don't want to work. It's not limiting patient access to the best physician. It's not forcing patients to only see doctors of their own race and ethnicity. Proximity is an important factor, but you also have to have physicians who are willing to work in disadvantaged communities and take governmental reimbursement. And patient choice also plays a role, as we've seen with respect to trust. And then the question arises, what is this professional, race-conscious professionalism? Is it that white and Asian physicians are choosing not to work in historically marginalized communities? Or is it that historically marginalized communities aren't welcoming to people who are from these different backgrounds? I think the answer is, it is that draw that brings people together because of racial concordance that really does it. There may be a factor that marginalized physicians aren't so welcome in certain communities, but I think it really is that professional consciousness that Black and brown physicians and indigenous physicians bring to the work that they do. Well, this is an important paper that was published in the National Bureau of Economic Research by my colleague Marcella Alson and Owen Garrick when she was at Stanford, and this is in Oakland. And they looked at Black men in Oakland, and they randomized them to physician practices they established with a Black doctor or a white doctor. And then what they did was they evaluated the interaction that took place and did some very elegant mathematics to do some projections on cardiovascular disease risk. What they found is that when the Black men went to a Black doctor, that the subjects were more likely to talk to that Black doctor about more of their medical problems and more of their health problems, that Black doctors were more likely to write additional longer notes about their subjects, and that through the calculations, they projected that cardiovascular disease impact could be significantly changed by racially concordant care, that you can improve the morbidity, the sickness from cardiovascular disease by 19%, and that you could reduce the mortality of cardiovascular death by almost 10%, just because of racially concordant care. And they felt this was because diabetes screening was up, cholesterol screening was up, and invasive testing was up in 20% in racially concordant relationships. And that return visits were up 20% in racially concordant visits. And that even flu shots were more likely to be had in a racially concordant relationship. This is the paper that really is of interest to perinatologists and OBGYNs. It was published in the Proceedings of the National Academy of Sciences back in September 2020. It's an association paper, so causation wasn't really linked to what was reported here. But they looked at 1.8 million live births in Florida between 1992 and 2015. And what they found is that the Black newborn death rate was almost 3 times that greater than that of white babies. But when they found that there was patient, baby, perinatologist, physician concordance with respect to race, that having a Black doctor, if you're a Black baby, increased your chance of actually surviving by 53 to 56%. Now, incidentally, there was no improvement based on maternal mortality based on racially concordant care from this particular study, but the study wasn't really designed to look at that particular variable. If you look at what happens in OB care with respect to who's delivering it, we understand that family medicine physicians deliver a lot of the OB care that's delivered in the United States. But what we find is that Black family medicine physicians are only half as likely to provide obstetrical care as do their white and Latinx counterparts. They're less likely to maintain continuing certification of obstetrical practice, and that, in fact, if you look at the workforce that takes care of patients who are in family medicine, you'll see that we need to have a more diverse and racially ethnic representation in maternal family care of people who come from historically marginalized groups. And we have to enhance efforts to diversify that workforce and encourage physicians to continue that care. If you look at what happens with trust with respect to COVID, this is another paper by Marcella Alsan and Fatima Cody Stanford. And what they talked about in this one is if you show videos of physicians of various races and ethnicities suggesting what they should do, what patients should do with respect to COVID, what you find that as a function of race, the people who view those videos, whether they're Black, Latinx, or other, you'll see that if a Black physician delivers the message, Black patients are more likely to seek additional information about COVID than if a physician of any other race gives the message. Didn't happen for Latinx individuals, that they didn't have a greater tendency to seek additional information if a Latinx physician delivered the message. But what Lisa Cooper actually commented on in the editorial in this paper is that ensuring that messages are accurate, available, and comprehensible is insufficient, and that recipients must also trust the messenger. And that trust is more likely when information is delivered by a messenger who is known and has a positive relationship with the community. Patient-centered communication doesn't explain heightened satisfaction scores with respect to concordance. That race concordance visits are longer, and as we talked about, characterized by more patient-positive affect, we found that that's linked to continuity of care, the tendency to come back for return visits. But this association isn't just because you're doing patient-centered communication. There are other factors, such as physician and patient attitudes, that may mediate that relationship. This is also work by Lisa Cooper. This is an article in New York Times that was really advising Black women how to protect yourself at birth. Now, that the Times had to actually tell women how to do this really speaks to the idea that people feel that they're not being taken care of in the same way. And they hear the statistics on maternal mortality, and people want information and knowledge to react to it. One of the things that you can look at is what happens when you have concordant care. It contributes to a more effective therapeutic relationship and improved healthcare in women. And so what we find in this situation is that for historically marginalized women, that emergency department use was lower among whites and Hispanics than it was people without a discordant clinician. And that, in fact, total healthcare expenditures were lower among Black, Asian, and Hispanic patients who had racially concordant clinicians, as opposed to those who had discordant clinicians. So having concordance in your physician relationship improves your care and reduces health cost outcomes as well. Well, this paper came out of Northwestern, in which they looked at almost 10,000 women. And they found that compared to non-Hispanic white women, that Hispanic and non-Hispanic Black women had significantly greater odds of reporting a pain score of 5 or higher in the immediate postpartum period. And that they received significantly less or fewer morphine milligram equivalents adjusted for race and non-adjusted data than their white counterparts. And that, in fact, that they were less likely to receive an opioid prescription at discharge. There was coverage in the Chicago Tribune about this article back in March of 2020, and it really talked about some experience of individuals who talked about their pain afterwards. And the idea that Hispanic and non-Hispanic Black women experience pain disparities less than white women is a significant factor in thinking about maternal care after delivery. And part of that was that physicians actually perceived that these women experience pain in a less human fashion, unfortunately. So the conclusions that I'd like to bring are that we need to create and expand funded measures to support increasing diversity of historically marginalized individuals in health careers in medicine, because we just don't have enough to even think about providing concordant care to all the communities that need it. We have to recognize the value of communication, trust, and safety, and educate all physicians as to how to deliver care in a way that delivers both better care and cultural humility care that protects patients from being abused in that relationship. We have to ensure that performance measures are valid, fair, and non-punitive for marginalized physicians who care for patients in these communities because of the great influence of the social determinants of health and politics. And then we have to consider incentivizing non-marginalized physicians as well to work in communities of marginalized patients, because some care is better than no care. But ensure that these individuals are equipped with cultural dexterity to manage these complex relationships with untrusting patients. Collect data on race and ethnicity of physicians, because we don't always do it in federal data sets. We have to recognize that if we don't know the race, we can't think about doing concordant care. Trust is earned. And so you have to think about what these physicians need to learn in their training and where they have to be able to advance and work in order to deliver the care in order to improve situations. And I'm going to stop there. Thank you for giving me the opportunity.
Thank you so much, Dr. McDade. Before we go into questions, we're going to go on and ask Patricia if she'll come on and do her presentation as well. Did we lose you, Pat?
I don't think so. Can you hear me?
I can, thank you.
I'm just waiting for my slides to come up. Next slide. I would actually like to thank Dr. McDade. Sometimes when you come behind someone who is presenting information that's similar to yours, you wonder whether they were, in the olden days, we would say copying off of you. So some of my information is going to be somewhat redundant, but a lot of the information that Dr. McDade presented was from the physician background. So what I would like to do is focus more on the midwifery. That maternal mortality is a key indicator of health inequity, which is impacted by social determinants of health more than behaviors and even clinical care. Although, next slide, clinical care is very important. Next slide. And as I said, go back one slide. Clinical care is extremely important, and it involves the immediate care team. And so who are the components of the immediate care team? It's the woman, it's the care providers, and that includes the clinicians, the nurses, the pharmacists, all of the individuals who would play a role in the care of the individual woman, and of course, her family member. Next slide, please. Next. So as Dr. McDade so eloquently stated, race concordant providers frequently, you're moving a little bit too fast for me. Just go back one slide, please. If you can go back one slide, that would be wonderful. Race concordant providers frequently reside in the same community and possess shared experiences of daily life, language, values, customs, mores, and cultural norms. Go back. I think you're moving a little. Yes, thank you. I will say next. Among clients who choose their providers, there was a preference for race concordance. And if you look at the Institute of Medicine and the Sullivan Report back in 2004, it stated that upon graduation, professionals of color consistently return to work and serve in their communities. And actually, I am a product of that. I was a National Health Service Corps recipient, and I specifically chose to go and work in the public institution in the community in which I resided. So this factor has facilitated the increased adherence with appointments and treatment plans. Patients report increased satisfaction, increased connection, increased comfort, respect, and trust. And as Dr. McDade stated, trust is earned, but trust before trust, you have to have developed a relationship. So trust is important, but it's the relationship that is the foundation for building trust. And when that is achieved, the patients had more confidence in the providers. They also had the highest level of satisfaction. And the goal of all patients, whether they are women, whether they are other individuals, the goal is to not only get them into the healthcare system, but for them to remain in the healthcare system. We have devised many services and programs and skilled clinicians, but if individuals will not enter the healthcare system and remain in the healthcare system, they will not take advantage of all the services that we have to provide. Next slide. You can advance to the next slide. So a lot of the information that I'm going to share came from the Listening and Giving Voice to Mothers survey that was conducted by a group called the Birth Lab. The Birth Lab is a group of researchers and scholars that is based in British Columbia. And they have literally spoken to and surveyed a lot of the women in terms of their satisfaction with the healthcare that they received and what were some of the barriers in the care that they received. Next slide. So women of color consistently report disrespectful care from obstetrical providers. Next slide. Mothers relayed a host of experiences with discrimination during childbirth and during their hospital stay. And it involved issues around race, ethnicity, language, insurance, and just a difference of opinion between the individual woman and her healthcare provider regarding care for herself and care for her baby. Next slide. Next slide. Women were asked, during your recent hospital stay, how often were you treated poorly because of your race, your ethnicity, cultural background, or language? And as you can see, for African American women, regardless of whether they were cared for by an obstetrician or by a midwife, both women, specifically Black women, but also Latinx women, reported experiences of disrespectful care. And I share this because often we don't speak to women, we don't listen to women, we don't know what women's perceptions were of the care that they received. So we're not really quite sure why they don't come back or why they discontinue their care. Next slide. Also from the Birth Lab, women described experiences of mistreatment during childbirth. 1 in 6 women experienced mistreatment during childbirth. The 4 most common types of mistreatment were being shouted at, refusing their request for help, visitation of violation of physical privacy, threatening to withhold treatment. And when you look at this broken down by race and ethnicity, Indigenous women, Latinx women, Black women, more often than not, experience more mistreatment in birth. Next slide. And this was from the Listening to Mothers, the California experience in 2016. And the question that was the information that was attempted to be elicited was, what were the women's future interests in birth center use based on the experiences that they had in hospital use for birth? And as you can see, the majority, when you look at the breakdown by race, African American women, and this was quite surprising to me, African American women Latinx women indicated that they were extremely interested in utilizing and would consider utilizing a birth center for their next birth. Next slide. Now, this slide I use quite often because it was extremely intriguing to me, because as a rule, at least my experience in a public hospital that served predominantly African-American women, most African-American women want their birth to be conducted in a hospital, primarily because of the availability of analgesia. But when you ask them after their hospital experience, how many would you be open to giving birth at home? Almost 30% of women, 18% said would consider, 11% said would definitely want. And you're talking about almost 30% of women who said that they would consider or be interested in having a home birth for their subsequent birth. Next slide. And again, this is just a breakdown, just a little bit more clarity in terms of race, in terms of having their next birth in a birth center. The impact of place of birth on mistreatment. The place of birth impacts the rate of mistreatment. 28% of women reported that they had higher rates of mistreatment in a hospital setting than in a community setting. When you looked at types of mistreatment by birth, 12% said that they were ignored by their provider or the providers refused help, as opposed to 2.5% in the home or 2.3% in a freestanding home, in a freestanding birth center. If you look at place of birth impacts mistreatment of women of color, almost 34% of women of color who gave birth in the hospital documented that they were mistreated, and 6.6%, as opposed to 6.6% of women who said that they were mistreated if they gave birth in a community setting. When you look at violation of physical privacy, almost 11% of women said that this occurred in a hospital setting, as opposed to 0.6% in a freestanding birth center and 0.8% in the home. If you look at the women who said that they were threatened by care providers, 6.6% occurred in a hospital, 4.2% in a birth center, 3.2% in a freestanding birth center, and 1.8% in the home. So there's something that's happening in the hospital that is saying to women that maybe the hospital is not a safe place for birth. And I don't think that that is the information that we want people to walk away from a hospital birth. That is not what we want them to take out of the hospital. Next slide. Next slide. So I am a certified nurse midwife, and my professional organization is the American College of Nurse Midwives. So when you look at ACNM in 2021, the midwifery community is extremely small. I think people believe that the midwifery community is actually larger than it actually is. But nationally, there are only 13,500 midwives in the entire country. 90% of those midwives are white and female, 10% are midwives of color, and midwives of color comprise Black, Latinx, Asian, and Indigenous midwives. So similar to the pattern that you would see with physicians, the geographic location of midwives demonstrate a similar pattern. So you have midwives who are literally concentrated in the urban cities, and then fewer in rural areas, and fewer still, well, mostly the urban areas and fewer in the rural areas. Next slide. Next slide. And when you look at the midwifery education programs, of the 40 education programs, 87% of them are headed by service directors who are white. 3 midwifery education programs are directed by midwives of color. 75% of the faculty are all white, and all new midwifery education programs are in predominantly white institutions. And so the message here is that if we're going to begin to increase the number of midwives of color, there needs to be a migration away from academic institutions into institutions that have historically educated not only most Black physicians, but mostly Black nurses. So you have your historically Black universities and colleges and universities. At the moment, the historically Black colleges and universities do not have any midwifery programs. Some have certified nurse anesthesia programs, but none have nurse midwifery programs. Next slide. And when you look at the ability to diversify the midwifery workforce, it becomes somewhat difficult, because when you look at the admission of students by race and ethnicity, there appears to be a underrepresentation of students of color and an overrepresentation of Caucasian midwives. So actually the only racial group that are congruent in terms of their representation within the national, the diversity of the US population are Black midwives, Black midwifery students. But if you look at the Latinx midwifery students, they are severely underrepresented, as are Asian midwives and Indigenous midwives, Alaskan Native midwives. Their representation in terms of students really underrepresented. Next slide. Next slide. So what are some of the pipeline concerns? Go back one slide, please. What are some of the pipeline concerns? Go back one slide. Can you go back to the pipeline slide? So what are the concerns for the pipelines? Well, number one, we need to increase the number of students, so that number two, we can increase the number of practitioners who ultimately graduate. Because we first need practitioners who subsequently become educators. We need to increase faculty in midwifery education programs. We need to also address the ability to retain practitioners once they graduate from midwifery education programs. Because what we're seeing in the midwifery community, although there is a decline in the numbers of practicing OBGYNs, and there seems to be an ability for midwives to fill this void. When it comes to midwives of color, once they have graduated, their ability to be employed, a lot of the data that we collect shows that they achieve employment at much lower rates. It takes them longer to be employed than their white counterparts. And once they become employed, the retention of them seems to be shorter. So we need students to come in so that they can graduate, become practitioners, become educators, become faculty, and also to become scholars. But ultimately, we need researchers, because it's clear that money needs to be allocated to research on race concordant outcomes. The information that we have and the data that we have on race, on outcomes based on race, primarily we have gleaned from research conducted by the physicians. Most data is physician-based. We don't, although there's an argument that can be made that the correlation to other professions, such as midwifery, should also be the same. So there's a dearth of information available on midwifery, on the midwifery side, on the impact of race concordant care, although anecdotally, we know that this is what women want. So we actually need to consciously and strategically begin to collect the data on these outcomes. And actually, what we do see, you can advance the slide, please. That research is just beginning. There is a midwifery group out of the University of Illinois in Chicago that just received a $7 million grant to literally research this very issue. They just received this grant approximately maybe a month or two ago. And so the research on midwifery care, race concordant midwifery care, is just beginning. What are some of the strategies that we could use on the midwifery side to address workforce diversity? Well, certainly there's federal legislation around workforce diversification. Certainly there's the MOMS bill and there's the Momnibus bill. The second thing is the funding, however, that is included in those bills, because unfortunately, some of those fundings lacks accountability metrics that I think is really important if we really are to achieve a diversity of the midwifery workforce. And some of those metrics really need to include how many students of color are enrolled, how many graduate, how many pass the certification exam, and then how long does it take them to become employed? Because the longer it takes a midwifery graduate to be employed, those individuals default to nursing positions, as opposed to continuing to try and secure employment in the midwifery field. So the amount of time that it takes a graduate midwifery to become employed is an important issue. And so these are some accountability metrics that the grantors of the funding in some of these federal legislations, hopefully if they are included, will address workforce diversification. And I think that's it. I'm finished.
Well, thank you so much, Patricia, as well as Dr. McDade. At this point, we're going to open it up. You provided a wonderful perspective for us to have a discussion about. So we're going to open it up for questions. I know there's one in the chat already, but as others are coming up with their questions, I'll start it off and ask both of you all. Are there any specific recommendations that you can pass over to SACIM that will really help us strengthen our current pipeline to diversify our providers? Do you have any specific recommendations to SACIM itself?
Well, so there's legislation I know that's being prepared by the House Ways and Means Committee. And my thinking on this one is that when Chairman Neal's work comes out, it's going to address trying to enhance the pipeline of individuals who come from underrepresented minority backgrounds. The thought is that we can look at people who are in post-baccalaureate programs, as well as people who are in the undergraduate phase. I think that we can think about earlier learners, but I think one of the most immediate returns you get is with post-baccalaureate learners who are pursuing careers in healthcare, because these are people who may not have had the preparation going to college, didn't do well in their first 2 years, but then caught up. And they represent a ready source of people who, with another opportunity, now that they're a little more mature, now that they've been exposed to college, could actually master those courses that they didn't master in the first 2 years. That stops them from being successful candidates for medical school. I think there are a lot of individuals like that that would benefit. And if that legislation goes forward, my hope is that we support that.
Belinda, there's a question in the chat about the focus seems to be on certified nurse midwives as opposed to certified professional midwives and certified midwives. Now, ACNM represents certified nurse midwives and certified midwives. So certified midwives are already taken care of. But the issue of certified professional midwives is actually an important issue, because that's another profession of midwives that we don't really talk about a lot, and they are there. Certified professional midwives don't work in the hospital. Certified professional midwives care for women in the community, in birth centers and in homes. The problem with, and it's not a problem, that's the wrong word. Certified professional midwives are only legal in 38 states. So whereas certified nurse midwives and certified midwives are legal in all 50 states. One avenue would be for SACIM to support legalization of certified professional midwives in all 50 states. Now, certified professional midwives have their own professional organization, the National Association of Certified Professional Midwives, but that is something that they have been advocating, and that is another source of midwives and midwifery care. The other group of individuals who actually could be a pipeline into midwifery education are doulas, because keep in mind, there are doulas and birth workers out there who are already involved in that space and are already doing some of the work. So to involve them in formal education is something that would enhance the capacity of the midwifery workforce.
Thank you, Patricia. And I see Janelle has her hand up with a question.
Thank you. This was a wonderful panel presentation, and I feel like the presentations should be given as a standard throughout medical school, midwifery school, any kind of health education science, and then again, as people graduate. I caught on to Dr. McDade that you shared about, the one of the pipeline issues that we could reach to earlier learners. And so, knowing that we have an immediate need and knowing that we can, affect some changes by looking at the current pool of students or post-bac programs, thinking long-term, knowing that there's going to be a shortage of nurses, physicians, likely midwives in the future for a growing population, what activities should we consider now that is going to, cover that gap coming up in 20, 30 years? I don't want to pass this mantle on to my children as they're adults or my grandchildren saying, well, I'm sorry, we did what we could at the time. So, how do we address this issue and how early should we look, and how do we, what does that look like? Do we involve communities? Do we, so that piece, but then also looking forward, what kind of research should be done on race concordant care that is going to help further our understanding or help us understand that we are doing what we should be doing? Thank you.
Well, my immediate answer is we have to do something to address the wealth gap that exists in our society with respect to underrepresented minority groups and the majority community. I think it really starts with education in general. And you ask how early. I've often asked the question, but have no tracking data on this. How many third graders do you need to talk to in order to make one physician? And the answer is you got to talk to a lot of them if they're underrepresented minority from historically marginalized groups. The point is that we have to do something to build the infrastructure in societies that really fixes the issue of inadequate education, inadequate preparation for higher education. We've got to graduate people from high schools. We have to fix the social justice system so that so many African-American men are incarcerated and dealing with the civil justice system as opposed to being able to be educated in higher education. I think it has to start with societal change, where we recognize the understructure of racism that exists that we have to eliminate from those practices in order to increase. Now, with that said, I think there are directed things that you can do for younger people, such as exposing them to job shadowing opportunities, to research participation. When I was a professor at the University of Chicago, for many years, I ran a program that we called SOMER, the Pritzker School of Medicine Experience and Research. We had another one we called YSTP, the Young Scientist Training Program. That one focused on high school students. And I had students from King High School in Chicago, a few blocks away from the University of Chicago, that ended up going to medical school. I've got one who's still there right now at Harvard in emergency medicine. I mean, the idea is that you can take kids from the inner city, expose them to opportunities and research at excellent institutions, and then you can drive their entire careers to become very successful. So I think that you have to expose people, you have to let them know that more opportunities exist than the ones that they may see in front of them, and that you have to then expose them to mentorship, directed mentorship. That's important. So those are the sorts of things I think are really effective.
Can I just, yeah, I'm going to echo what Dr. McDade just said. One of the things that was very interesting to me when I began my midwifery career in 1982, every patient I would meet always said, first of all, they didn't know that they were midwives, and then they didn't know that they were Black midwives. And so very early in the careers of students, they have to be able to see us so that they know that we're out there, and they know that we exist, and that we can be role models for what they can be. And if you just look at tennis and what has happened in tennis, if you look at the young group of tennis players that we have today, who were their role models? Venus and Serena Williams. Most of them, if you ask them, grew up watching Venus and Serena play tennis, and they said, oh, I can do that. And they watched them at a very, very early age. So the other thing that we need to do, and I'm going to comment on Dr. Conroy's comment about advocating for various categories of midwives, because in fact, Dr. Conroy is correct that the International Confederation of Midwives recommended minimum levels of education for training. But we also know that there have been adjustments to that, and that no one is advocating non-formal education. Formal education is absolutely what we want. We want people to be the best educated, the best skilled, the best informed. There are schools, certified professional midwifery schools, and for graduates of those schools, depending upon the state that they go to, they are not able to practice. So the goal should be to enable any CPM student who graduates from an accredited formal education to be legal in a state that she would like to practice in. I think that would be the goal.
Thank you. I see Colleen's hand is up as well.
Yeah. Hello. Thank you for those presentations. They were fantastic. I have a couple of questions, like they're unrelated, but for especially Dr. McDade. And I live in Chicago like you do, but the physician basically desert that you showed on your map where, you know, comparing the north side to Inglewood. So like, how do you think, and maybe you kind of answered that in what you just said in reference to the last question, because it's probably more of a systemic issue, but when you think of the decreased life expectancy for the groups that come from that part of the city versus the other part of the city, like how does that overlap with the issues of like violence? And so is it, yes, it's a component of, are they receiving proper health care? For sure, if they can't get to seek out medical assistance. How do you look at that overlap with the issues of violent crime that might be more, or they are more frequent in Inglewood than the northern part of the city? I was just part of a vaccination drive in Inglewood, and the day that we were there, a 7-year-old girl was shot in the head and killed. So I think that when you look at statistics for life expectancy, it's clearly other things besides just medical condition. And so how do you kind of, is it like a overlapping circle, do you think, or is it more of a pyramid shape? Like, how do you kind of ferret out some details? It's kind of, I think, related to what you just said, where it's probably more issues of helping education, helping decrease the wealth gap and things like that are just issues of daily living. So I think you kind of answered already. That's my first question. So you can answer that, or I can ask my second one.
Well, I can answer the first one, and then we can go to your second one.
Okay.
So the first one, I think you're right. It's the social determinants of health. It's political determinants of health that we talked about in the presentation. And I don't think that gun violence contributes significantly to the overall deaths in longevity. I think that the life expectancy has been pretty low for African Americans in this country, that really preceded the immense handgun violence and gun violence that's taken place in Inglewood over the last few decades. When I was a medical student, one of the things that was said about the life expectancy of Black doctors, as it turns out, was that the average life expectancy of a Black doctor was 64 years of age. And that's in part because of the allostatic load that doctors have always had, that Black doctors have always had, that the Black community has always had. So the fact is that these violent peaks that we've been seeing lately has been contributory, but I don't think it explains even in a large factor why life expectancy is so low. I think it's the everyday sorts of lack of access to care, lack of access to good food, lack of access to education and transportation, all those social determinants of health that really explain it far more than I think violence. But the violence is a part of it. And if we could reduce hand violence to zero, I'd be the first person in line to say we should do that.
Okay, thank you. And then my other question is just about the study from Florida that showed the increased rate of death for Black babies 3 times being that of white. And that the second part of that about the discordance between providers, I think and obviously you've read the study, but I feel like this study is frequently mentioned in the press and everywhere. And when you actually look at the study, I don't think most people know that like the way neonatology works is, there's a team of people. So this study looked at who was the admitting doctor for each baby, and then Googled a picture of that doctor, and then a panel had to decide what race is that person based on their thumbnail picture. So I guess I have 2 problems with that, because it's so frequently cited, the study, and in neonatology, whoever your admitting doctor really could be someone that took care of you for 1 day versus the other 2 months of your hospital stay. And there is a component of someone just looking at a thumbnail picture and deciding what race someone is, but they did try to describe that it was kind of repeated. So they showed some, I guess, strength in that approach, but like, I don't know if you could, like, tying the outcome of the baby to the one person's name is on the chart. Like where I work at Northwestern, there's one woman who's the director of the NICU. Her name's on every single chart, and she might not have taken care of any of those babies, but she's bureaucratically in charge of the whole place. So I feel like whenever that study is mentioned, there should be a little caveat, because I don't think that that's the strongest data set that they use to prove that point. But
So I'll agree with you that there are some limitations to the study, that's for sure. I was talking to the director of the HRSA program for, I'm blanking on the name of the program right now, but this really deals with the underserved communities that are served by HRSA. And I asked him, I was a member of the board of the Joint Commission at the time, and I asked him whether we collect data on race and ethnicity of the practitioners who are part of that program that serve the underserved in that HRSA program. And he said, well, no. He actually, as deputy with him, he turned to ask her whether it was true that we don't collect it, and the answer was no, we don't. I think we need to collect race and ethnicity information from the practitioners so we can do more direct analysis of the impact of racial concordance, because looking at photographs is certainly one of the most inferior ways that you could possibly imagine for trying to determine the race and ethnicity of providers. I also think that looking at a chart to try to go backwards to see who was actually caring for a patient, because we do care for patients in teams. Now, admittedly, Northwestern has a huge practice, and they have an advanced group of folks who are taking care of people. So, is it the nurse that takes care of the patient? Is it the physician team member who's a resident, who's the best person that's associated? Is it the attending physician who actually supervises the teaching team? We work as a team, and I wish there was some way to acknowledge that the impact is the case. But I think at the numbers that we saw, 3 to 1, with the paucity of underrepresented physicians that there are, I think there's probably some merit in that particular study, and that the concordance thing should be studied at a much deeper level. So thanks for that question, pointing out the caveat.
Thank you.
For your presentation.
Thanks, Colleen. Our last question, we're going to let Wanda Barfield ask the final question. Wanda, you're muted, I think.
Oh, I just wanted to thank our panelists for an incredible presentation. Thank you very much. So although we're trying to think about ways to increase the pipeline, I think it's also important to acknowledge the sort of missteps that have occurred in time. You know, I trained around the time of affirmative action, where there were increases in the diversity of providers. And then I was actually trained undergrad in California, and the Bakke decision came out just about the time that I was ready to graduate from college. And I wanted the panelists to talk a little bit about these systemic obstacles that do occur in addressing the pipeline, and also what would you suggest, particularly in trying to advise young health professionals in going into these professions, yet seeing debt as a major barrier, and maybe even tying it to the earlier discussion that we had, how do we create optimism about the opportunities before students already make the decision that they're not going to be a health professional? Thank you.
Can I take the second question, the debt question first? Because after listening to Captain Williams this morning from HRSA, more and more, at least midwifery students, that's my area of expertise is midwifery. Most of the midwifery students qualify for National Health Student Corps loan repayment. And so to the extent that students are encouraged to apply for those grants, that would eliminate and remove the barrier. Your first question, however, is the harder question, because I grew up also during that time of the Bakke decision. I think as we focus on maternal mortality, I think there has to be serious discussion. A lot of what Dr. McDade showed, a lot of what I showed, says that there has been an overrepresentation historically. And so there has to be a way to create that balance, somehow come to the middle, so that the capacity of providers of color, which was really the foundation for that whole Bakke decision, they didn't want to do that. But I think we need to revisit that because I think that's the only way we're going to, make progress. That discussion has to be put back on the table.
I'll just say that I don't know why I was blanking on federally qualified health system centers. That's what I was looking for. But the idea is that in the legislation that we just discussed, that's coming out of Chairman Neal's office, I think one of the things that is in there is how do you impact those postbacks? Because you finish college, you've used up all your Pell Grant money. You have to work potentially in order to do those postback programs, and they're very expensive. And if you work while trying to do a post-bac program, you won't do as well as you would otherwise have done. And then that's your second shot that you're going to blow. So I think there has to be federal support that goes along with those programs in order to make them work. And you have really keyed in on an important aspect of it. I think that in order well, as a politician once said, that you don't talk to me about values, show me your budget statement and I'll show you your values. So that if we really value trying to drive people into the health sciences, we have to figure out how to value that by actually attaching aid that's going to support those underserved individuals and being able to pursue it. And that's really one way of addressing the wealth gap. Jordy Cohn, who was the president of the AAMC at the time, showed data that looked at MCAT performance, and that the higher your parental income, the higher you performed on the MCAT, and that 80% of medical students who are matriculants actually come from the top 1% of all earners. And so when you look at that disproportion, you can see why it's not really accessible, at least in the minds of many folks. And AAMC started a program over a decade ago called aspiringdocs.org to really talk to them about this issue of finance. But I don't think that's a sufficient effort. We have to figure out some way of making money available so that we can educate people and do it at a cost that they can actually afford. When a year of tuition costs more than the house that your parents live in, you're not going to pursue medicine.
Please join me in thanking both of our presenters. This has been a wonderful discussion. I will say that we're just beginning it. By no means should this be the end, but we appreciate both of your time and effort in participating today. So thank you so much.
Yes.
Thank you for allowing me to participate.
Thank you, Patricia, for actually advocating for this session. Patricia was really the moving force for having this session, so I really, really appreciate that.
Thank you.
And before we move on, we're going to go over 10 minutes because this was an important discussion, and I know the data discussion is also important. But I want to make one point of one of my biases, and this follows what Paul Weiss said about accountability. It irritates me that all of the land grant institutions that were basically given indigenous land in order to develop higher education are not being held accountable for training the people in their states that they were charged to do. And I think that we need to hold these institutions, most of them are public institutions, hold them accountable for the training of the people that in their state that represents their state. So that's what our job is at the state level. So with that, turn it over to Magda for the session on data, another important session.
Thank you. Well, thank you, Ed. I welcome you all just to take literally 30 seconds just to breathe, because we're going to make a transition and I want you to be ready to shift a bit. So whatever you need to do for about 30 seconds, this is worthwhile so that you can focus your attention and then savor the extraordinary presentations from our previous speakers. I will also ask if it's possible that when I am speaking, our technical folks, I have a profound hearing disability. And so I call in twice, and I would prefer if you, when I am speaking, if you could pin me, this one, and not the one who's speaking. So if you can figure that out technologically, that will help. And for all of you who share hearing impairment, I'm your advocate. So I am absolutely ready for advocacy in that area. So this last session today is about data, yes, but it is more importantly about data for action, data that are used, data that are usable, data that are used for accountability, advocacy, and impact. Because data alone never speak for themselves. So this final session, which we've titled Data for Action, Strengthening Maternal and Child Health Related Sentinel Event Review Approaches. And I'll talk about that in a second, systems and uses. So we're gonna focus on two in particular, maternal mortality review and fetal and infant mortality review. And we'll also add child fatality review because it's part of a life course approach of being able to take vulnerable and extraordinary times of opportunity by looking at the numerator, not just the denominator. There have been long-standing and plentiful aggregated public and population health data. We have looked for rate, ratios, p-values, and proportions in our work to prevent infant and maternal mortality. But there are egregious and significant events that demand more detailed attention and summon us to ask one by one, every time, 3 questions. Why did this happen? Could this have been prevented? And what needs to change at every level, individual through society, for it not to happen again? For about 40 years, 4 decades, Sentinel Health Review methods have been part of our public health and population health and prevention toolkits. I know this because 40 years ago, I worked on my dissertation at Harvard about preventable pediatric hospitalization, defining Sentinel Health event, use of data to be able to look at cases one by one that should not have happened in the first place or not have been so severe. Now, the Joint Commission on Accreditation of Healthcare Organizations defines a sentinel event as any unanticipated or unusual event in a medical setting, which results in death
or serious physical injury to a person or persons, and it specifically cites limb loss or gross motor function. A clearly clinical lens is currently used by the Joint Commission. And the intention is to improve quality of medical care. More recently, as social and environmental determinants of health have been incorporated into sentinel event review, it's been to look at unmet need. So I would concur that maternal deaths and fetal deaths and infant deaths, most are indeed avoidable events. And it is our obligation to look beyond the aggregate quantitative data systems alone to ask, again, why did it happen? How could it have been prevented? And what needs to change at multiple levels? Our Sentinel Health Review systems in maternal and child health give us tools to do just that. And in December of 2019, this organization, SACIM, received comprehensive baseline briefings from the Maternal and Child Health Bureau and from CDC on maternal mortality and child fatality reviews. We learned about fetal, infant, child, and maternal mortality review methods, systems, and approaches, how combining clinical, professional, and community level expertise would give us insights to give recommendations that could matter. We also heard from Dr. Wanda Barfield about how maternal mortality review committees and the MARIA program, and more recently a Race Maternal Mortality Initiative, is strengthening capacity in more and more states. And we also heard how case-by-case review approaches are being used not only in maternal, fetal, infant, and child death review, but adapting these to maternal morbidity as a concept, mother-to-baby transmission of HIV, opioid-related deaths, births impacted by Zika and congenital syphilis. In other words, taking it from the mortality review to the morbidity space where single events sound the whistles for us to pay attention. This organization, SACIM, published a series of recommendations and put them forth to Secretary Becerra in August. And one part included the augmentation of mortality and morbidity review. Today, nearly 2 years after our original briefing, we're going to dive a little deeper this afternoon, into these comprehensive, coordinated, community-engaged case review systems that are designed to yield data for action, not data for interest, that will allow us to have greater sharpened tools and stronger tools in our toolbox for the prevention of maternal, fetal, infant, and child deaths. And we'll hear from two panelists who will each have about 10, 12 minutes to be able to give us an update. And then they're going to talk to each other, because one of our hopes is that there'll be even greater integration of maternal, fetal, infant, and child death review processes than there are now. And I will be introducing you to Sarah Kinsman and Julie Zaharatos in just a sec. Let me tell you that I've queued them up front to respond to 4 questions. So you should know what they're responding to versus a generic presentation. We've had that. This is a strategy session on how to get the data stronger, used, and of greater utility in an integrated, leveraged way. First, so how is it working really well to impact policy and program? 2, how are they aligned with each other and leveraging each other and being used for greater impact across the life course, as well as outside of the maternal and child health purview? What do they need to have to strengthen these unique sentinel health approaches and case reviews to have even stronger tools in the toolbox, especially to address health equity and to bring forth the voices of lived experience? And if we were wildly successful with this set of tools for data to action, what does it look like when success is there to have greatest impact? Finally, we are, and SACIM, and in our data and research to action work group, highly cognizant of forces and factors that in some places constrain utility and use. there is limited resources and folks are more strapped than ever. People working in maternal and infant and child death reviews have been pulled into COVID, and there isn't enough resources to begin with. And so folks are working on resourceful ways. We know that there are concerns that are raised about defining fetal death and questioning what is viability and when should the reviews begin. And there are tensions that play out in many communities. We know, as Ed mentioned up front today, that there is resistance growing to centering racial equity and asking the hard questions about why mothers and babies die, to the point of some places not being able to speak or inquire about the impact of racism on outcomes. And last, we know that when recommendations are perceived to be at odds with powerful positions or agendas, there may be withholding of findings based on evidence in the politicization of data that has become more pervasive. So we've also asked our panelists to say, how have your systems fared amidst COVID, and what more is needed for data and discoveries from these processes to be able to have the impact and drive decisions that can prevent maternal and infant deaths. So towards that end, without further ado, we're going to start with Julie Zaharatos, who is the lead for partnerships and resources with the Maternal Mortality Prevention Team at the Division of Reproductive Health at the National Center for Chronic Disease Prevention and Health Promotion at CDC. Julie works with stakeholders around the country to promote better understanding of the causes and factors contributing to maternal mortality. She's on the front lines to producing technical assistance and reports, and including applying health equity frameworks to the work of maternal mortality reviews. And previously, she served as Maternal and Child Health Program Director for the March of Dimes in Georgia, and has been actively involved in mortality review work herself. We'll also hear from Sarah Brett Kinsman. Dr. Kinsman serves as the Director of the Division of Child, Adolescent, and Family Health in the Maternal and Child Health Bureau of the Health Resources and Services Administration. Is the division has a longstanding work to advance strength-based health promotion, enhance injury prevention in schools and communities. But before joining HRSA, as of recent, Dr. Kinsman served as Director of the Division of Maternal and Child Health, Child and Family Health in the Philadelphia Department of Health. And she has firsthand knowledge of how these different case review systems work in harmony in a major city in the country. Also a former board member of City Match. And she comes with a background in pediatrics and adolescent medicine, and was a Robert Wood Johnson clinical scholar in epidemiology with a PhD in sociology. So we want to bring both and thank them for their service, if you will, what is their noble work that we do, according to prior MCHB Director Vince Hutchins. And we ask them to give us an update of what we need to know now, not to tell us about the systems, but how are they working and what needs to happen for them to be even stronger tools. Julie, would you join us, please?
Absolutely. Thank you so much for that kind introduction, Magda, and thank you to SACIM for having us here today. Can you see my full slides there on your screen?
We can see your slides, and you should remove my spotlight and go to Julie so you can see her. Thank you.
Great, thank you. And thank you for the opportunity to provide an update on enhancing reviews and surveillance to eliminate maternal mortality. Again, I'm Julie Zaharatos of CDC's Maternal Mortality Prevention Team in the Division of Reproductive Health based here in Atlanta. I know that the SACIM members have heard about our work before, and I will focus this presentation on efforts to strengthen the state and local level maternal mortality review committee process itself to pave the way for better local level maternal mortality data. As a reminder, maternal mortality review committees, or MMRCs, seek to provide a deeper understanding of maternal mortality through understanding both the medical and non-medical contributors to deaths and developing and prioritizing recommendations that may reduce future deaths. They do this by reviewing death certificates and any linked birth or fetal death certificates, medical records, social service records, mental health records, autopsy, and in some cases, informant interviews. Note that MMRCs include representatives from public health, obstetrics and gynecology, maternal fetal medicine, nursing, midwifery, forensic pathology, social work, mental health, behavioral health, and members of the community. To learn more, you can refer to our review of a cardiomyopathy death that was published in AJOG, and you can see the link to experience an MMRC in action that are both included in your briefing book. Currently, there are 50 existing maternal mortality reviews in the United States, in 47 states and in 2 cities and Washington, D.C. This represents significant progress since 2015. At that time, there were roughly 20 existing MMRCs. Our CDC team began working with the existing reviews at that time. We learned that common definitions of maternal mortality and approaches to abstraction and review were necessary in order for comparable data to be gathered at the local level. Starting in 2016, we embarked on a project called Building U.S. Capacity to Review and Prevent Maternal Deaths. In 3 years, we worked with the existing review committees to build a data system. We also helped 25 new state and local reviews get off the ground with training for abstractors, analysts, committee chairs, networking opportunities via regional and national meetings, and job aids to support their work. Now, we specifically support 50 state and local MMRCs in this work by making the Maternal Mortality Review Information Application available. MMRIA, or MARIA, is a CDC data system that provides a common data language for MMRCs, facilitating their functions and promoting a national approach. Of 50 existing MMRCs, 48 are currently using MARIA. MARIA facilitates documentation of a wide range of data on the life and death of a woman to ensure a review committee can develop strong prevention recommendations. Over time, we have added components to MARIA based on feedback from users that have facilitated enhanced data collection on things like substance use, discrimination, and racism. As more states collect comparable review data with a truly multidisciplinary membership that is reflective of the communities most impacted, the data will improve and point the way to eliminate preventable pregnancy-related mortality in the United States. Beginning in 2019, we were also able to provide direct funding to some MMRCs. In fiscal year 2021, Congress appropriated funds allowing CDC's Erase Maternal Mortality program to directly fund 30 jurisdictions, supporting review programs in 31 states. To read more, you can refer to our Erase Maternal Mortality paper that was recently published in the Journal of Women's Health and is also in your briefing book. As noted earlier, Erase Maternal Mortality supports all 50 states in their work to identify, review, and document opportunities to prevent maternal mortality through MARIA and other training and technical assistance. Before I leave this slide, I want to answer the question of how MMRCs have fared amidst the COVID pandemic. Largely, the work of our state-level MMRC awardees and other state partners has continued in the virtual space, providing us the opportunity to visit without travel. In addition, we have connected awardees through virtual peer observations, leveraging the opportunity of the new virtual norm for enhanced peer learning opportunities. Here are the steps of maternal mortality review. You can also refer to your briefing book to see our MARIA Committee Decisions Form, which is referenced here. It starts with staff presenting each selected case to the MMRC using a case narrative. The MMRC discusses and makes key decisions about each death. They enter key decisions into the MARIA data system, then move on to analyze data, identify key issues and recommendations themes, and prioritize and disseminate findings. Epidemiologists who support the work export the data from MARIA to identify leading causes of death, timing in relation to pregnancy, and to calculate a pregnancy-related mortality ratio. Here is MMRC data on causes of pregnancy-related deaths by race. This can be an important tool for jurisdictions who want to reduce disparities by prioritizing interventions that address the leading causes of deaths to Black women, for example. You can also see here that the leading cause of death for Black and white women are different. The contribution of mental health conditions to pregnancy-related deaths are captured by MMRCs, while other data systems cannot capture this level of information. MMRC data has also shown us that the distribution of pregnancy-related deaths vary by timing of death in relation to pregnancy. Both cardiomyopathy and mental health conditions are leading causes of death overall, but also leading causes of death in the late postpartum period, which underscores the importance of examining the full year postpartum. And the last step is to prioritize recommendations for action and to disseminate them. In 2020, 14 state MMRCs published a report using their Maria data, a number equivalent to the total number of reports published by MMRCs between 2015 and 2019 combined. And those data can lead to change. Illinois put their first Maternal Mortality Review Committee report out in October of 2018. The state legislature introduced 15 bills that address the recommendations from the MMRC. As a result, Illinois became the first state to extend Medicaid coverage to 1 year postpartum. Perhaps it goes without saying that the quality of maternal mortality analyses depends on the quality of the maternal mortality data. We are working with MMRCs to ensure high quality data by providing guidance on how to collect complete data or as complete data as possible. To do this, deaths are identified, abstracted, reviewed, and entered into our Maria data system in a timely manner. We provide regular technical assistance on the data being abstracted toward Maria data entry being consistent and accurate. For example, maternal mortality review committees should be reviewing all suicide or overdose cases in a timely manner. One example of what we've done is that since 2016, we have developed and disseminated guidance on how to comprehensively identify pregnancy-associated deaths and review them in a timely, accurate, and consistent and complete manner. But data quality is dependent on process quality. We spend a lot of time with states on process quality. Who is at the table? Is your MMRC membership inclusive? Is it possible to bring in more context via community level health indicators and informant interviews? A focus of our technical assistance promotes the importance of diversifying committee members beyond clinicians. MMRCs have historically been led by and largely comprised of clinicians who bring medical expertise, years of experience, hours of unpaid time, and passion to preventing maternal mortality. MMRC recommendations commonly focus on medical care, and that may reflect the comfort zone of clinicians. However, clinician leaders are learning that they need to share that responsibility in handling and addressing maternal mortality. And so teams are bringing in more community-based and health policy perspectives. And this can help them to identify more community-level contributing factors to make recommendations that recognize community context and draw on community strengths and knowledge. In addition to the training, we published a health affairs piece on the importance of including diverse voices in MMRCs, which is also included in your briefing book. Just want to note that erased maternal mortality funded states are held accountable for having non-clinical members to participate in their MMRCs, and more recently through a formal collaboration with the Black Mamas Matter Alliance or BMMA and AMCHIP, we are considering how MMRCs share power and support community engagement. In addition to the work to support community engagement, CDC has several efforts to improve components of the MMRC process at different stages, which also address health equity. We've looked at some of the Maria quantitative data so far in this presentation, and that demonstrates the importance of supporting further review program capacity to analyze qualitative data. Looking at qualitative data from Maria for substance use deaths, several important themes are captured. Qualitative analysis of this data allows programs to demonstrate where missed opportunities for screening and getting individuals into treatment for substance use disorder contribute to deaths. As examples here, some individuals in the analysis had missed and incomplete prenatal care, narrowing the window for screening. It was more common to see substance use screenings in emergency room records in Maria data, which are often not shared with primary, prenatal, labor and delivery, or postpartum care providers. Qualitative analysis has also helped to understand contributors to maternal overdose deaths, such as loss of child, for example. That was a key stressor in overdose death review findings. I share this to emphasize the importance of investing in routine qualitative data review for programs. This context can tell an important story of ways to prevent future deaths. Further CDC investments in MMRC processes quality include informant interview resources. Medical records capture perceptions of patients from the healthcare provider perspective. What's missing is patient and family perceptions of providers and systems. We convened 5 jurisdictions to help us develop an MMRC informant interview guide that provides tools to help capture the woman's perspective through next of kin interviews. There are currently a handful of states that are implementing interviews. One state MMRC chair said, now that she has them, she cannot imagine reviewing cases without them. And there is growing recognition that discrimination, including interpersonal and structural racism, contributes to adverse maternal health outcomes. And we have heard from MMRCs that bias and discrimination have played an important role as contributing factors leading to death. A work group of MMRC members and subject matter experts came together to understand and capture bias as a potential factor in maternal mortality review. The work culminated in the addition of discrimination, interpersonal racism, and structural racism as data fields available in MARIA. And now, as part of a partnership with the Office of Minority Health, we are working with the American College of Obstetricians and Gynecologists to help MMRCs with tools to identify discrimination and racism in medical records that can ultimately be expanded for use in medical settings. We are also working with the National Birth Equity Collaborative and NBEC scholars on an early analysis of documentation of discrimination and racism in MARIA, and building on the BMMA work to examine how MMRCs connect with community partners, and to ask perinatal quality collaboratives, or PQCs, how they do this, and ask PQCs if they see themselves in MMRC recommendations. We also have work with Emory University to develop case-level community vital signs dashboards. This will be via a portal that will enable MMRCs to better identify points at which disparities occur, helping to put the woman's life and death into the context of her community. Community vital signs dashboard will be complemented by guidance on how to integrate community level indicators into abstractions and reviews, as well as a policy menu that will assist MMRCs in developing recommendations, particularly at the system and community level, to reduce maternal mortalities amongst all groups. We anticipate that MARIA users will have access to the portal for generating case-level dashboards by September 2022. To learn more, refer to our Changing the Conversation, Applying a Health Equity Framework to MMRC's paper published in AJOG. It is also included in your briefing book. American Indian and Alaska Native populations face a significant maternal mortality burden. While maternal mortality review committees have the capacity to identify and implement prevention strategies, there are currently no tribally led MMRCs, and too few state-based MMRCs have tribal representation. While having tribes represented on state MMRCs is important, it does not equate to tribally led MMRC that serves Native people's needs. To achieve that goal, we are working with the National Indian Health Board. NIHB is working to assist tribes and tribal organizations in designing and implementing tribally led MMRCs. In the coming year, NIHB will be providing in-person and virtual trainings and building a resource library on maternal health and maternal mortality in Indian country. They will also be supporting Indian health boards or tribes directly via grants and technical assistance to conduct a readiness assessment. The focus of our work together is to develop the foundations necessary for implementing tribally led MMRCs that respect Native culture and result in meaningful and effective prevention strategies for Native communities. We have come this far with the help of dedicated and innovative partners, and our vision is that these data that the MMRCs are collecting and reporting will inform action. Some examples are that maternal health care standards, tools, and resources will be implemented with a linkage to an understanding of the leading causes of pregnancy-related death within that jurisdiction, and that these jurisdictions will be prioritizing right place, right time interventions that are informed by these MARIA analyses and engaging community partners. Thank you again for hearing us out, and happy to move on and get into the Q&A portion too.
Excellent, Julie. Thank you so much for that terrific update. Without further ado, we're going to go to Dr. Kinsman, knowing that we'll be running about 10 minutes past our time. So we give Dr. Kinsman her due today, and we'll hold all questions until the end. Sarah?
Thank you so much, Magda. I think the slides should be coming up soon. Here we go. I want to start today. Chris has that. I'm going to start today as the slides come up. So first, I'm going to be presenting on behalf of the Maternal Child Health Bureau's National Fetal Infant Child Death Review Program and our cooperative agreement recipient, the National Center for Fatality Review and Prevention at the Michigan Public Health Institute. With me today is Diane Pilkey, Commander Mary Emanuel from MCHB, and Abby Collier and Rosemary Fournier from the National Center for Fatality Review and Prevention. I mean, their work is so strong, and they have really, as you will hear today, responded so beautifully to many of the challenges we've had in the last year. I was nominated to present most likely because, as Magda shared, and prior to coming to HRSA, I was the Director of Maternal, Child, and Family Health for the Philadelphia Department of Public Health. And there I led the Fetal Infant Mortality Review Team for the City of Philadelphia. I served on the Philadelphia Maternity Mortality Review Team, which was just for the City of Philadelphia. I served on the Act 33 Child Abuse and Child Fatality and Near Fatality Review Team. And I also served on the Prevention of Perinatal HIV Transmission Fetal Infant Mortality Review. I have to tell you that the work that we did there and I was able to experience richly expanded our understanding of vital statistics data. It made all the difference. And the power of developing a team of knowledgeable and passionate volunteers, and I want to emphasize volunteers that collectively made a difference, is one of the most important parts of my career. And I think speaks to how valuable this work is. Next slide, please. So I'm just gonna ask, there may be a delay, so I apologize if there's a delay. Next slide, please. The Maternal Child Health Bureau's, oops, back one slide. Sorry, everybody. The Maternal Child Health Bureau's vision is an America where all mothers, children, and families are thriving and reach their full potential. Next slide. So what I'm going to talk today is about our overall program, the National Fetal Infant Child Death Review Program. We have supported this program at MCHB for over 30 years. These fatality reviews are integral to our state Title V block grant program and also our Healthy Start program. And they provide insight into gaps in services, systems, and modifiable risk factors that can really hopefully we can empower folks to create the changes we need. CDR's motto, so on the side here, is really keep kids alive. And I think that being positive with this work is so incredibly important. And really the way that these teams have developed is to think about what's the future and what can we change. For FEMUR, the motto, so to speak, is more first birthdays. And the ultimate goal of these systematic reviews, as you know, is to identify risk factors, individual, clinical, community, system, policy, and then most importantly, make a change. Next slide. So for the child death review, I'm going to start with that first. And child death review is a multidisciplinary process where teams meet to discuss information to better understand how and why children die and to inform prevention efforts to reduce future child fatalities. Child death review typically reviews deaths from infancy through age 17. Next slide, please. So there are over about 1,300 child death review teams in the United States. They are located in all 50 states and the District of Columbia. 9 states are working to develop tribal CDR teams, the center has been working really closely to expand this effort and to help these teams integrate CDR into their processes. State legislation impacts the types of fatalities that are reviewed and also some aspects of the review. 44 states mandate or permit child death reviews teams to do their work, and 27 mandate or permit local CDR teams. The lead agency varies. In 29 states, the lead agency is the state health department. In 10 states, they're led by social service agencies. And in other states, they're led by medical examiners, attorney generals, or hospitals. Funding is important and comes Title V block grant funding supports CDR in 23 states. 22 states are supported by the CDC's SUID and SDY case registry forms and works in conjunction with our program here. So we have a platform and then they are able to provide support to enrich some of the work looking at SUID and SDY. Other important funding include CAPA and state funds. Next slide. So case selection varies by states. Now, this slide just shows the percentage of states that generally look at these types of deaths. So we can see that most states are able to look at SUID deaths, unintentional injuries, undetermined deaths, abuse, neglect, homicides, suicides, and children who have received protective services, opioid-related deaths, but less commonly are states that are able to review foster care and medical deaths. Now, this does not mean that all states are able to look at 100% or 98% of SUID deaths. It just means these are the types of deaths that various states have the jurisdictional responsibility and ability to review. Next slide, please. So the child death review process is depicted here. And really the reason I'm doing this, I want to be very helpful for all of you who might be familiar with FEMUR and not CDR, so that you can understand the difference between these two approaches to reviews. A multidisciplinary child death review team comes together and they share relevant information about the child's death from the perspective of their agencies. Their agency might be a social service agency, school, law enforcement, or emergency medical services. Folks pre-hospital emergency medical services. And they would talk about what they know about the child, the family, or any other relevant pieces of that discussion. Typically, the agency that has the most information starts to share, and then other folks add in. And once the information is on the table, the team tries to identify risks and whether the death was preventable or what could have been done to prevent the death. The lead agency typically enters data into the National Fatality Review reporting system, which we'll talk about in a little bit. And then the CDR team works to catalyze prevention efforts. Now, 43 states have state advisory boards that to some degree work to advance prevention efforts. And we'll share some examples as we go. Next slide, please. So let's talk about fetal infant mortality review. So fetal infant mortality review is a community-based, action-oriented process of reviewing de-identified fetal and infant death cases to make recommendations and develop and implement innovative local actions and improve systems of care, services, and resources for women, infants, and families. And one of the important things for fetal infant mortality review is that it is de-identified data. And that allows folks to stay more focused on some of the system changes that we'd like to see. Next slide, please. So in total, there are 154 FEMUR programs in 27 states, the District of Columbia and US territories. 82% are led by state or local health departments. Authorization mainly happens through local legislative mandates, such as local health surveillance or local health codes. 72% are funded by Title V block grant funding, and many get support from the Healthy Start program. As with CDR, case selection varies by community, and because this is much more intensive process, not all cases are selected, or as I mentioned, in the city of Philadelphia, we might focus on one type of case for one femur. So the perinatal HIV femur focused on one type of risk factor. And our general femur also focused just on sleep-related deaths, just so we could really hone in on that. So femurs tend to do that sometimes. Next slide. So the way this works is that prior to meeting, records are abstracted and de-identified. The records come from multiple sources: medical records, prenatal care records, home visiting records, WIC records if they're available. And then there's a family interview, and the family interview allows for the voices of the parents and family and caregivers to share the challenges that led to the infant deaths. Prior to COVID-19, about 62% of femurs were attempting to obtain parental family interviews, and 30% were successful. It is challenging to interview somebody and interview a family right after their death of their child. And it takes an incredibly skilled provider to be able to do that. These stories provide significant information about health equity, disparities among diverse populations. I just have to share one example of two 15-year-olds that were trying to keep their infants safe. And they had worked so hard to do it. You know, they left their house, one person's house, because there was work being done in the street and the baby might get dust. So they went to another person's house and they tried to set up the bed and you just hear how hard they worked to do. In this example, it was safe sleep. And then sadly, they failed because they were not able to keep the child in their own specific environment, infant sleep environment. So I had to tell you, I think that this is an incredibly important part of the reviews, and it's exciting to know that Maternal Mortality Review is working to do that as well. The other pieces, so what happens is the case review team looks at all this information. So they look at the de-identified data, they look at the family interview if they're there. Sometimes the family interview was being shared as the folks who are trying to do the family interview and why it was so hard for the family to communicate, which is also very important. And then that team looks at the data and develops recommendations. And the folks on that team are usually very clinically oriented or people who are in the field. And then that information goes to the community action team. And the community action team is generally comprised of those who have political will or the ability to take the case review team's assessments and recommendations and to prioritize those and to implement them, whether they be system change or policy change. And this is to reduce whatever type of mortality they're focused on. Next slide, please. Great, thank you. So that's the process. And I didn't focus as much on the data, but at each point, the teams pull their data together, and many teams share their data with the center. And so I want to go through how the data is collected and how we use it. So here on the right side, you will see a data entry page for our case reporting system, and it shows you how a child death review manager would enter data, and they can click on each question so that the data dictionary pops up. They can explain the variable, and we're really working on increasing the capacity to have very strong data quality in the last couple of years. On the right side, I'll talk about this a little more, is what we do with the data and how it comes out, and that is Child Dash. Next slide, please. So the National Fatality Review Case Review Reporting System is the core of our prevention efforts, in addition to what we've been sharing. The case reporting system is a web-based standardized case reporting platform. About 92% of CDRs enter case data, summary findings, and team recommendations. Since 2009, 250,000 cases have been entered into this system, which is about a third of all deaths that are in the vital statistics case reporting system. So we don't see all the deaths, but we see a good portion of those deaths. In addition, an estimated 40% of femur teams are entering data, and the femur system came a little later, so those teams are on a different curve in doing this. Since 2018, 7,000 cases have been entered into the system. In the past few years, as I shared, there's been a real focus on improving data quality, which allows us to create standardized and really useful standardized reports. And I show you an example of infant safe sleep on a national level. And here you can see where the age is at the top, sex of the infants. And then if we look here, we see obviously that non-Hispanic Black infants are overrepresented in this sample. It gives us a picture of what some of the demographics of the cases that are in our case reporting system. It helps us to think nationally about what we should focus on. Next slide, please. Great. So here, what we know is that 47 states use the case reporting system. About 50% of case reporting of cases are infant deaths. So I think there's a misunderstanding sometimes, and folks think that all infant deaths are in fetal infant mortality review, but in fact, 50% of the case review cases are infant deaths. So we have cumulatively 127,000 cases. These represent, as I mentioned before, approximately 33% of all infant deaths. And of the cases that are in the case review system, about 3,000 are femur teen cases are in the CRS. Most common causes of fetal death reviews are congenital anomalies, prematurity, asphyxia, and SUIDs. And here I just want to say sleeping on the surface. So here's a little snippet of what we can get from the cumulative data. And here we see the question is, was the infant sleeping on a shared sleeping surface with a parent? And here you see for the infants that died from a sleep-related death, over almost 60%, 56% were sharing a sleep surface with a parent. Next slide, please. So this is new and it's really exciting. The National Center has created a dashboard. It is called the Child Dynamic Analysis and Statistics Hub, or Child Dash. The website summarizes information from the child death review, and it is really wonderful. It's important to know that the states own their own data still, even though it is part of this national a dashboard, so they can actually see data from their own state, and then we are able to see national level data if you work with the center to be able to assess data and look at some of the particular areas of focus that the center has created dashboards for. And those dashboards are fire and burn, drowning, motor vehicle, firearm, poisoning, etc. And of course, infant safe sleep, which I'm showing you here. Next slide, please. Magda asked us to look at the impact of COVID on fatality reviews, and it has been significant and it will be significant. Child death reviews and femur teams experienced delays during the reviews. They started doing virtual reviews. State and local staff were reassigned. They had to manage that. In the National Center, one of the wonderful things about their work has been to be able to be very nimble and allow for quick change. So within 3 months of the COVID pandemic, they were able to modify and include COVID-19 questions as a cause of death, whether it's directly related to COVID-19 pandemic or indirectly related. For example, a child that was whose parents were afraid to go to the hospital and passed away with asthma en route to the hospital. That system has been modified as the pandemic has changed, and so we're really grateful for being able to do this. The other thing that the center has been able to do is to really help teams become virtual teams, which was new, and some states have absolutely loved it because it's easier for them to get together, and some are very excited about going back in person. And then self-care resources is really important. It is hard to do child death reviews, and I think that the center has been really helpful in assessing the needs of our coordinators throughout the country, understanding that they are going back into the pandemic. Not that we're out of it now, but they will go right back into it because there is a lag time in these reviews. So they'll be reviewing COVID cases going forward. And the sensitivity to that and supporting that is really important for these teams to continue to work as hard as they have been working and will be working going forward. Next slide. So what is the impact? One way is publications. And so I believe we were able to sneak these into your packet. Looking at some of the publications in the last 2 years related to the fatalities reviews is very important. Next slide.
And Sarah, we're gonna need to wrap up in just a little bit because we're running way over time. So thank you so much. Can you bring some of these examples forward? And then we'll have a little chance to close it up. So sorry to interrupt.
FEMA is working with the Wisconsin Department of Health, Public Services. I think I'm still live. Okay, good. Okay, great. Just want to be sure. And they have worked with the Wisconsin Title V program to really use CDR data to inform relevant, consistent, clear, and concise messages on infant sleep, which have been great. In Maryland, FEMA and Baltimore realized that 50% of women whose infants had died were not included in the Maryland perinatal risk assessment, which is a mandatory assessment for all women who receive are eligible for Medicaid. And the OB providers just had too much difficulty using that system. And so they did a focused effort to address that issue, which has been very effective. And in Colorado, legislation was recently passed for paid parental leave. And while this was an effort of many folks throughout Colorado, data from the fatality reviews were used to support passing this bill. And this was a consistent recommendation of the CDR in Colorado. Next slide, please. So I hope I've been able to share that there are impacts that we can measure, and I've shared some of those wins. And then the process of doing a fatality review for a community is incredibly important. It improves communication, you improve data collection and a focus on that. You improve how systems and agencies work together. You're working on really profoundly moving and experiences, whether they be the death of an infant or tragically the death of somebody in the pregnancy period. And I think that as we continue to do this work, we'll be able to even make a greater impact in the future. And if you have any questions, next slide. And you go to the last slide, but you can find, please feel free to reach out to me at any time. And I would love to hear your ideas and your thoughts. And Magda, I return it back to you. Thank you all so much.
Thank you, Sarah, for that terrific overview. We have exceeded our time allotment for today, and I don't want to shortchange the conversation, but pragmatically, what I'd like to encourage before I pass it back to Ed is that members of SACIM who have been listening during this time, as well as ex officio members, if we could have an opportunity for you to put questions that you have in the chat before we end for today. You can also, we'll open it for a minute or two tomorrow morning, which will be my morning, your afternoon at the kickoff, so that we don't lose any thoughts here. And then the Data and Research to Action work group will be looking to see how do we take these updates, further integrate the work of these two extraordinary systems, and then leverage that for even greater impact. With that, I'm going to not take questions in the interest of time now, but again, put your questions in the chat. We'll revisit it first thing in the morning. And Ed, I'd like to pass it back to you for a brief closing. And thank you very much to Julie and to Sarah for bringing their brilliance and their experience and expertise with us today. Ed?
Thank you, Magda, and thanks to our presenters there, Julie and Sarah. It was excellent. We will revisit this, but not at the beginning of tomorrow, because I really don't want to interfere with the first sessions that we have. I'm hoping that after our break tomorrow afternoon, we will be able to get back when we have our sort of general discussion. We can add that time. And Julie and Sarah, I hope you can join us for some brief questions at that point in time, but we will get back to that. But put your questions in the chat. Also, be thinking about recommendations that you want to make before you leave, before you turn off your computer and go out for a bike ride or a walk or whatever you're going to do to make up for this 4 hours of sitting. Think about some recommendations that you may want SACIM to be thinking about as we move forward. And my last thought was tomorrow we're going to talk a little bit, I'm going to talk very briefly about narrative and how narrative really shapes a lot of the programs and policies. And I remember back when Bill Foege and Michael McGinnis went from the death certificate causes of death to the real causes of death. And that changed the narrative about what creates health. Jim Marks had a paper on that also in American Journal of Public Health, from what we think of the leading causes of death to the real causes of death. And what I'm seeing from the data that both of these efforts are bringing, that we're actually going to be able to say, yeah, it might be maternal hemorrhage, it might be embolism, but the real causes of death are. And I'm hoping that we will be able to get that so we can start to change the narrative about health for moms and babies in this country in the same way that we brought tobacco and lack of physical activity and alcohol to saying that's what we really have to focus on. And so I think some of the racism, the poverty, the lack of education, the discordant care, all of those things. So keep that in mind. And now everybody else, go take care of yourself, stay healthy, and we'll see you tomorrow at noon Eastern Daylight Time on the first day of fall.